Good morning to all. I am Paresh Prabhugaonkar from Nirvin Life Sciences. On behalf of Nirvin Life Sciences, I welcome you all for this live webinar on thrombotic microangiopathies and interesting hematology, ID cases with management issues. I extend my warm welcome to both our guest speakers of the day, Professor Dr. M.B. Agarwal and Dr. Ayusha Sunawala. Also, a warm welcome to our chief guest for the day, Professor Dr. Pratit Sandani, as well as to all the discussants present on this platform. I now request Professor Dr. M.B. Agarwal to take up the webinar ahead. Thank you.
Thank you, Paresh. Good morning to everyone from India. Good afternoon and good evening if you are in different parts of the world. Once again, we have registrations from 27 countries today, over 450 registrations. And thank you very much for sparing your Sunday for academic activity. So today's first lecture is on thrombotic microangiopathies that will be delivered by me. We have second lecture on interesting hematology, infectious diseases cases with management issues. And the speaker is our colleague, Dr. Ayesha Sunawala, who is an ID specialist. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Nirvin Life Sciences and managed by Perfect Square. I thank Mr. Paresh Prabhugaonkar and the team from Nirvin Life Sciences, Mr. Yash and Kalpesh and the team Perfect Square, the Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Pratit Sandani, our guest speaker, Dr. Ayesha Sunawala, all our discussants who are eminent hematologists and medical oncologists from different parts of India, you participants for sparing your Sunday morning, afternoon, or evening. Just to remind you, from this evening, we begin our marathon lymphoma webinar, which will be today at 6:25 p.m. onwards up to 9:30 p.m. We have 15 very important guest speakers from all across the world, and you can see their names and photos on the right side of this slide. We have 15 lectures on different lymphomas starting from today for next 5 days. And this will be fascinating for those who are doing malignant hematology and medical oncology. So every day, 6:25 p.m. onwards, join us if you are free. Next Saturday evening, 6:30 p.m., we have Hodgkin lymphoma management issues in 2022 by Dr. Ellison from Memorial. And next Sunday morning at 11:30, we have Dr. Ganesh Jayashetwa talking about transplants. And as you know, he's from Hyderabad. So that's the menu for this week and weekend. Remember to visit the website of Mumbai Hematology Group, www.mhgindia.com. It gives you all the details of our academic activities, which are going to be held in next month or two. And it also puts up all the slide sets that the lectures have been delivered and where the speaker has permitted us to put up the slide set. Our discussants today are virtually who is who from different parts of India, alphabetically displayed here. We have Dr. Ankit Rayani from Ahmedabad, Dr. Gunjan Lone from Nagpur, Dr. Gunjan Prasad from Kolkata, Dr. Manoj Toshniwal from Aurangabad, Dr. Nishad Dhakate from Nagpur, Dr. Prashanta Bhatt from Mangaluru, Dr. Sameer Malinkari from Pune, Dr. Sandeep Nimani from Niraj, Dr. Sanjeev from Lucknow, of course, at the moment he's from UK, Dr. Satish Kumar A from Bangalore, Dr. S.P. Verma from Lucknow, Dr. Shilpa Prabhu from Bangalore, Dr. Shruti Mantri from Aurangabad, Dr. S.S. Ray from Kolkata, Dr. Tejaswini Gudipande from Bangalore, Dr. Varun Bafna from Kolhapur, Dr. Vikas Goyal from Raipur. Now it's time to introduce our chief guest for the day, my colleague and friend, Professor Dr. Pratit Sandani. To the hematology and oncology group from India and across the world, it's important for me to introduce him. However, Mumbai and the community of physicians and intensivists know him extremely well. To complete the formality, he is Deputy Coordinator, Internal Medicine. He's a renowned internal medicine specialist and intensivist at multiple hospitals in South Mumbai, and to be specific, Bridge Candy Hospital, Sir H.N. Reliance Foundation Hospital, Jaslok Hospital, Bhatia Hospital, and Saifi Hospital. That means there is no hospital in South Mumbai that is left where he does not give his services. His credentials are phenomenal. His MD Medicine, FCPS Medicine, DNB IHCA, MBBS Bombay, F Card, SAS-MS, FCCP, T Card, F Med, SAS-MS, FCCP Allergy, FCCP T Pulmonary, and FCCM USA. Wonderful credentials. Over the last decade, he has been conducting research and clinical studies on various drugs and disease conditions. His research papers have been published in various fora and journals of repute. He has served as the principal investigator, co-investigator for various clinical trials. He has presented numerous papers during various national and international conferences, both India and abroad. He is a recipient of Excellence in Internal Medicine Award 2012 in 2013 Mumbai. He is also a recipient of Excellence in Medicine Award in 2012 New Delhi. He did MD Internal Medicine from Bombay University, followed by fellowship from Society of Critical Care Medicine, New York, way back in 2005. He is member of the Governing Council, College of Physicians and Surgeons, 2012, Society of Advanced Studies in Medical Sciences, Association of College of Chest Physicians. Well, that was his formal introduction, but to me, he's a colleague, and I learn a lot of medicine by interacting with him whenever he invites me to comment on the hematological problem of his huge practice at Pichkandi Hospital. I request him to inaugurate our today's webinar and give some words of wisdom. So over to you, Dr. Pratik Samdani.
Morning, everyone. Thank you very much, sir, for a very, very kind introduction. And it's indeed a pleasure to be at this hematological meet this morning. So I'm just going to be speaking without any slides, as I've been told, because I have to speak for 3 minutes. And I think the last 2-3 years have changed the way we should start thinking if we've already not changed. And I want to ask every person hearing me today that what makes us happy and healthy today? This is a non-medical talk, but it has some medical insights to life. I want to ask everyone what makes us happy and healthy today as we age specifically. Is it, our growing interest in the future that is going to make us happy just because of good wealth? Is it because of good health? Is it both? Is it relationships? So when you actually surveyed some people, 80% of these people said it's money, and then came fame for the remainder 20. And I think that's pretty much obvious. If you ask someone, what's their goal and aim in life, the first will be money for most people. We all constantly are told to work hard and harder and harder and spin the wheel, keep working harder until we get a flat tire one day, then only to realize that we were just spinning the wheel and crushing the wheels of life, and we did nothing else. And this is so much true for the medical fraternity. Most of us, if you want to know of a human life, we go back and look at the past. But when we start and think of the past, we actually realize that we only remember few anecdotes, and the entire life is not remembered. Past and memory, to me, is absolutely downright creative. Now, where did this thought of mine come from? As we grow up, our entire life goes in struggling for the best for everyone, for us, for our family members, etc. I started when I was at the Harvard Medical School. There was this ongoing study, and this is an extremely interesting study. So this had 724 subjects, and this study was 75 years, and it's ongoing. So it's on since 1938, and it's still ongoing. Year on year, the investigators, spoke about these 724 subjects. They were all men for a change, and they started asking about their job, their health, their family life. And it's such a rare study because no study will last for 75 years, max at 10. And you know why? The subjects may fall, the investigators drop out, many will die. At this stage today, there are 60 out of these 724 principal subjects who are still alive, and obviously they're in the 90s. And now they've started actually interviewing next gen, because there are 2,000 of the siblings and the great grandsons following ahead. And what did they do? 1938, 2 groups, sophomores. Sophomores are typically second-year students who are at Boston and Howard College. It's not medical college, it's engineering and medical. And one was boys who were from the neighborhood of Boston, Massachusetts, and they were from a low community. I mean, when I say community, socioeconomic status, they actually interviewed them. They went to their houses. They took a consent. Everything in America is done with the consent. They did physical examination. They did mechanical examination. They saw their medical history. And then they followed them up for years. They realized many became big workers. Some of them became goldsmiths. Some elite became professionals like doctors, engineers. One of these people actually became the United States President of America too. So they had a vast gamut of these subjects, because that's why they divided them into two different kinds of people. Some turned alcoholic as they grew. Some actually rose from the bottom to the top. And the select few, unfortunately, from the top came down. Every 2 years, this questionnaire still continues to everyone. And they do the same thing. They interview them, they review their medical records, they scan their brains, they speak to their siblings, their wives, their children, and they talk to their doctors and find out about their status. What was the learning of this? And I think this is the most important line. It was not wealth, it was not fame, it was not hard work. It was just good relationships that kept them happiness, that kept their happiness and sanity intact, even at 80 and 90. And I'll tell you what this actually means. It doesn't mean just happiness in a way of saying happiness. Social connections were the most important part. And it was really, really good to have a good, healthy, and happier life when you were 80 or 90, when you had good social connections early in life. They said connect with family, connect with friends, connect with the community if you have none. Happiness and healthier and longevity are all dependent on social connectivity. Loneliness was clearly shown as as a very toxic experience. So those subjects who were lonely actually did worse when they turned older in terms of health, mental health, physical health, aptitude, memory, everything. And even cognitive decline was much more when they were lonely. They also realized that the brain function decreased in the lonely characters. It was not only the friends and family that was important, not the number, but the quality of friends and family that's more important. It was studied that the quality is so important. If you're living in the midst of conflict, it's terrible. They've had a bad outcome, conflicting marriages, unhappy states at home led to worsening of all their cognitive decline. Of course, people who had warmer relationships, actually, they showed out they were more protective towards all this ill. One group, actually, they followed this 80-year-old group of men who were doing so well in life. They went back to their midlife. Typically, in humanity, we say midlife crisis, 40 to 50, 55. That's a midlife crisis, when you've earned money or you don't have money, or you're settled, unsettled, whatever. And they studied that people who had a good relationship at the age of 50 and 45, 50, 55 actually did better. And that's how they proved that happiness is a quotient of good relationships in the past. It's almost like a legacy effect. It wasn't actually the number of their cholesterol value. It wasn't their BMI. It wasn't their weight. It was interpersonal relationships. And I think it is so important to keep our mental health happy and good as we progress in age, because if we don't do this today at this age at 40 and 50, we'll never be happy if we live to 80 and 90. The last thing that they came out, that it protected neurons, it protected brains. So if you had good relationships in the past, your memory, cognitive decline, etc., was much, much less. This is a no-brainer. I mean, it's not rocket science or it's not wisdom. It's as old as the hills. How do you do this? It's very easy to say, but it's actually easier to do. Replace your screen time with people time, talk to people, go out with family, call your relative over the phone, even if you've not spoken for the last 20, 30 years, it will make a change. Go for long walks, go for a date with your wife, if nothing else. As Mark Twain said, at the end, I'd like to say, there isn't time so brief is life for bickerings, apologies, callings to count, and heartburnings. There is only time for loving. But that's just an instant to speak. So I think we must all gather, especially after what we've learned in the last 2.5, 3 years, that happiness is a quotient of not wealth, of not well-being, but a quotient of the mind. So keep yourself happy, do everything else that you should do, not just practice medicine, and relationships, happy relationships, have a happier ending ahead. Thank you, sir.
Oh my God, fantastic, Dr. Pratik Samdani. Such a superb talk. I don't think we have had a better opening to any webinar than this. Full of messaging.
Privilege.
And I think very, very relevant to me at least. It's so important, so important. The message that you've given, I only hope that people have heard everything. They have digested everything. If you don't mind, if you can give this, I'll put it up at our website. It's so beautiful. Let them read it again and again and again and again, and they will probably take some time to digest each sentence. If they can follow this, I think they will be very, very happy. You have given them what happiness is and how to be happy. Wow. Tremendous.
That's so interesting that they actually did PET CT brains and followed up with doctors, the medical records, and they found this. So it's actually a scientific study. It's not a. So,
And thank you for preparing this
thank
for
you.
us and delivering it. Thank you.
Thank you, sir.
We have to move on now. So we will again, I'll share my screen. We start with now the Sunday quiz. As you know, that Sunday quiz is for everybody. Today's quiz is related to hepatosplenic T-cell lymphoma. I'm going to show you 11 statements. Only one statement is correct. There are 10 false statements. You have to just pick up the correct statement. And as you know, there will be a number to each statement. And that number you have to email to me, mbagarwal1@gmail.com. And once again, as you know, the fastest finger first will be the winner. You get your prize. And we are going to tell you the names of all those who sent the correct answers, as well as the order in which the correct answers were received. Okay, so just a second. Yeah, so here are the 11 statements for hepatosplenic T-cell lymphoma. 1. It accounts for 15% of peripheral T-cell lymphomas. 2. It is common at elderly age. 3. It is more common in females. 4. Besides hepatosplenomegaly, as the name suggests, lymphadenopathy is a common feature. 5. B symptoms, that is fever and others, are unusual at initial presentation. 6. Cytopenias are rare. 7. Hemophagocytosis is uncommon. 8. Histologically, sinusoidal pattern is uncommon. 9. Over 80% are alpha beta T cell, while less than 20% are gamma delta T cell type. 10. Patients having inflammatory bowel disease and its treatment with chemotherapeutic or biological agents have a higher incidence of PTCL. And the last one, transplantation in first remission is not recommended. I like to just make a correction. In the 10th one, it's not PTCL, but it is HSTCL, hepatosplenic T-cell lymphoma. Please pardon me for the mistake here. So that's the 10th statement, that patients with inflammatory bowel disease treatment with chemotherapeutic and or biological agents have a higher incidence of hepatosplenic T-cell lymphoma. So I'll keep this slide on for a few seconds. Only one statement of this is correct. 10 are wrong. Whatever is the number of that correct statement, email it to mbagarwal1@gmail.com. Okay. So that was already told to you. Now we go to the weekly case. So this is a 67-year-old male from Coimbatore, referred for a mass in pancreatic head on sonography. Physical examination was unremarkable. CECT revealed a slowly enhancing 4 centimeters multinodular mass in the pancreatic head, and there was enlarged lymph node in the mesentery. There's no evidence of biliary or pancreatic duct dilatation and no evidence of chronic pancreatitis. PET CT showed metabolically active mass with SUV of 9.2 and the lymph node had SUV of 3.2. A contrast enhanced endoscopic ultrasound showed similar findings. Differential diagnosis was IgG4 related pancreatitis pancreatic carcinoma, or any other disease. EUS FNA was performed, and this was followed by a laparoscopic biopsy of both the mass in the head of the pancreas as well as the lymph node. Histology showed a dense monotonous proliferation of atypical lymphoid cells. IHC showed a follicular lymphoma, grade 1-2, CD5 negative, CD10 positive, CD20 positive, BCL2 positive, BCL6 positive, and MUB negative. The Ki67 labeling index was low, 18. Both upper and lower GI scopies were unremarkable. Bone marrow aspiration biopsy were negative. A diagnosis of primary pancreatic follicular lymphoma was made. In view of the possibility that this can lead to a biliary obstruction and the risk of that was high, it was decided that despite it being a follicular lymphoma localized to the pancreas and a lymph node and patient having no B symptoms, it's important to treat him. We gave him bendamustine obinutuzumab 6 cycles. He achieved CR and there were minimal adverse effects. He has then gone on to complete open maintenance for 2 years. He had neutropenia without fever as the only adverse event. And now he's off treatment for a year and living a very comfortable, productive life. There has been no relapse so far. Primary pancreatic lymphomas are rare. Usually when the pancreas shows lymphoma, it is involvement of lymphoma from a primary nodal lymphoma. The commonest subtype is DLBCL. Only 36 cases of primary pancreatic follicular lymphoma have been reported in English literature. And these form a part of 2 large studies, which are on primary pancreatic lymphoma in general. Mean age at diagnosis is 67 years, and the males outnumber females 9:1. Majority of them, 70%, had a pancreatic head mass. Either EUS FNA or a laparoscopic biopsy of the pancreatic mass or the lymph node is usually adequate to give you the diagnosis. Most of the patients, unlike pancreatic adenocarcinoma, do not have biliary obstruction. Surgery, chemotherapy, and radiotherapy have been used as the modality of treatment. Surgery was actually done only for those patients where the diagnosis was, or a wrong diagnosis was, pancreatic adenocarcinoma before a final diagnosis. Once a lymphoma is diagnosed, then the surgery is avoidable, prognosis is favorable, and the survival is long. Well, that was our case for the day. And we now go for my lecture on thrombotic microangiopathy. Hi, today we are going to talk about thrombotic microangiopathy. I'd like to introduce 3 terms: schistocytes, microangiopathic hemolytic anemia, and thrombotic microangiopathy. Schistocytes means fragmented RBCs, and this is what they look like. Microangiopathic hemolytic anemia requires that there is a hemolytic anemia as characterized by low hemoglobin, reticulocytosis, raised indirect hyperbilirubinemia, raised SGOT, and raised LDH, and almost absent haptoglobin. Microangiopathic hemolytic anemia signifies that the hemolysis is because of stenosis of the small vessels, that is arterioles and the capillaries. And that's what is called thrombotic microangiopathy. In thrombotic microangiopathy, the vasculature of arterioles and capillaries has narrowed because of the thrombus lying there. So overall, thrombotic microangiopathies are a group of disorders which are characterized by microangiopathic hemolytic anemia, thrombocytopenia, and microthrombi, leading to the ischemic injury to the tissue. These are rare conditions, but they are life-threatening and therefore require urgent management. Unfortunately, the presenting symptoms are very non-specific, but the basic lab tests are very important pointer because there is invariably thrombocytopenia, anemia, RBC fragmentation, and evidence of hemolysis. Primary care or emergency department physicians are often the first point of contact. But once the diagnosis is suspected, there is an urgent reference to be made to the hematologist or nephrologist who will provide the specific treatment. So this is graphic presentation of what I spoke so far. So there is arteriolar stenosis, which is due to thrombi. The thrombus consumes platelets, so there is thrombocytopenia. And the abnormal shear stress leads to broken RBCs as seen in the diagram here. And this ischemia leads to organ dysfunction. The organ ischemia is an emergency. You can get involvement of the brain leading to infarcts as shown over here. These infarcts could be quite subtle as shown by the arrows in the cerebellum here. The deleterious neurological impact of diagnostic delay can lead to fatality. Similarly, when the heart is involved, it could lead to myocardial infarction, as you see on the left side, and there is thrombus in the vessel on the right side. This is a post-mortem specimen showing how the hemorrhage can also occur in the myocardium. And this is a publication, Myocardial Infarction as an early presentation of TTP. TMAs can involve the small bowel, leading to acute ischemic injury and submucosal hemorrhage. And it can involve the kidney, leading to thrombi in the renal vasculature. This can happen during pregnancy. And in pregnancy, this could happen in the first, second, or third trimester, and even in the postpartum period. There will be placental infarcts, as seen in the vasculature of the placenta over here. TTP and pregnancy, its presentation, management, and subsequent pregnancy outcome, beautifully published by Mary Scully from UK in this article. The commonest of the example is of acquired TTP, but there could be congenital TTP affecting kids. So pediatric TTP has to be remembered as published in this and the subsequent article. So once again, to summarize this part of my talk, thrombotic microangiopathy can have various kind of examples. The two commonest ones are TTP and hemolytic uremic syndrome, popularly known as HUS. And this hemolytic uremic syndrome could be typical or the atypical. The typical one is related to the E. coli toxin, and the atypical one is related to abnormalities in the alternate complement pathway. This is what is called primary, and then there could be secondary, HUS or TTP, and this can happen in the setting of stem cell transplant, pregnancy, drugs, hypertension, infection, autoimmune disorders, malignancies, etc. And if you can't find a cause, it could be an idiopathic HUS. How common are these entities? So if you look at it, the complement-mediated atypical HUS is the rarest. The Shiga toxin producing E. coli-associated hemolytic uremic syndrome is the commonest. And the immune TTP is somewhere in between. Today, in the time that I have at my disposal, we will talk basically about TTP, that is thrombotic thrombocytopenic purpura. As stated earlier, it's rare. The annual incidence is just about 3 to 6 new cases per million. The mortality of this disorder has significantly come down, and in 2022, it's just about 10 to 20%. Almost 100 years ago, that is 1924, Moskowitz described the first case of what we call today as TTP and was called as Moskowitz syndrome in those days. He described a classical pentad of fever, transient focal neurological symptoms, nephropathy, together with severe thrombocytopenia and microangiopathic hemolytic anemia. And his original case was a 16-year-old girl. And this is what is called the historical pentad of TTP: fever, anemia, thrombocytopenia, neurological findings, and renal failure. Now, going more about the history of TTP, almost up to 1980, the etiology of TTP remained unknown and the fatality was over 90%. It was in 1982 when it was detected that plasma of patients with TTP have very large multimers of von Willebrand factor. And these ultra-large von Willebrand multimers lead to the platelet addition and aggregation, and this causes microthrombi of the microvasculature. And that was shown in 1985. These thrombi contain only platelet von Willebrand factor. They do not contain fibrinogen. Because there are large amount of these von Willebrand multimers, which are ultra large, plasma exchange was thought as an effective treatment, and it was started in 1986. And it was shown to be effective, and it saved 85% of patients. Why do these patients have ultra-large von Willebrand factor multimers? It was 10 years later, that in 1996, that an enzyme, ADAMTS13, was identified. And very soon it was documented that there is an antibody against ADAMTS13. As a result of which ADAMTS levels are below 10% in these patients. And this finding is a specific biomarker for TTP. These antibodies reduce the level of ADAMTS13, as a result of which the normal function of ADAMTS13, that is to clip the von Willebrand factor, does not take place, and there are large amount of these multimers which are circulating, leading to thrombi. The antibody against ADAMTS13 is of IgG in nature. Also, interestingly, in about 1/4 of the patient of acquired TTP, these antibodies are not detectable. And as stated earlier, there could be genetic conditions which are not due to antibody, but because of a biallelic mutation in the ADAMTS gene. And there are almost more than 150 subtypes of this mutation described. Let's come to the pathophysiology of TTP. So by now you must have understood the normal job of ADAMTS13 is to cut the von Willebrand factor, leading to small molecular weight VWF. That's the normal phenomenon. So ADAMTS13 is a protease enzyme. That's the structure of ADAMTS13. ADAMTS13 words stands for A, disintegrin, and metalloproteinase with a thrombospondin type 1 motif number 13. So this is sort of a nickname. And this is a VWF cleaving protease. That's the part of the ADAMTS13 which has the capacity to bind to the VWF-A2 domain. This is von Willebrand factor. That's the A2 domain. That's the binding site for the ADAMTS13. And that's how the ADAMTS13 binds to the A2 site at von Willebrand factor and clips it. Now, this cartoon will tell you the normal physiology and what happens in TTP. So you've got platelets, you've got von Willebrand factor, and there is a normal platelet addition and aggregation. ADAMTS13 keeps the von Willebrand factor clipped, so there are no large macromolecules and a normal amount of clotting takes place. Now imagine a situation where there is no ADAMTS13 because of this antibody or congenital mutation. In that situation, there will be these large multimeric forms of von Willebrand leading to excess of addition and aggregation of platelet and thrombi in the microvasculature. So the same is shown to you in this flow diagram. So there is severe deficiency of ADAMTS13 below 10%, either due to genetic mutation or due to acquired antibody, and there can be some trigger factor. This leads to accumulation of ultra-large, hyperadhesive multibus of von Willebrand factor in the plasma. That leads to spontaneous formation of platelet thrombi in the microvasculature. This causes consumption of thrombi and broken RBC, leading to microangiopathic hemolytic anemia. And because of decreased blood supply, multi-visceral ischemia. So there are many players, some known and some unknown. The known players are one that we have seen, that there is ADAMTS13 severe deficiency due to antibody or gene mutation. And then there are predisposing factors. In US, females outnumber males, and that's shown all over the world. Black ethnicity is a predisposing factor, and there is a HLA-DRB1 star 11, which is closely correlated with acquired TTP. And most of these patients are obese. So obesity, black ethnicity, female gender, and HLA-DRB1 star 11 predisposition. Then there can be precipitating factors like inflammation, infection, and pregnancy, all of which, as we know, lead to increased level of von Willebrand factor. And then there are unknown players. These unknown players could be protein and cellular. Cellular, there could be some problem with the platelet or the endothelial cells, and we do not exactly know this in details. And on the protein candidate, this could be a problem with the cell receptor, carrier protein for the ADAMTS. There could be some physiological inhibitor for ADAMTS13. There could be variability in the von Willebrand factor sensitivity to ADAMTS13, and there can be linkage to von Willebrand factor polymorphism or factor H. Let's come to something simple, that is clinical profile of these patients. So what you see over here are circles and squares. The circle means inherited TTP, so it's less common, and acquired means, the blue means the acquired TTP. So majority of the patients are adult onset, but there is also pediatric onset. And in pediatric age group, there could be acquired cases, and in adults, there could be genetic cases. In fact, when pregnancy is the trigger factor, large number of patients have underlying mutations. That means they are genetic, though first presenting during pregnancy in adult women. The historical pentad that I talked about is seen in less than 10% of patients. And if you wait for that, it will be a delayed diagnosis. The most constant signs are two. One is severe thrombocytopenia, usually platelet count below 30,000. The second is presence of cystocytes. Organ ischemia could involve brain in 60% of patients, leading to headache, confusion, stroke, convulsion, coma. Intestine in 35% of cases, leading to abdominal pain, diarrhea. Heart in 25% of patients, it could be as subtle as ECG changes right up to myocardial infarction. And kidney, there are usually subtle abnormalities causing proteinuria, hematuria, almost never acute renal shutdown, almost never creatinine going above 2 milligram. 60% of TTPs are primary immune TTPs, and the rest have one or the other condition or the trigger factor. So this summarizes the clinical presentation. Patient may come to you with brain dysfunction, GI problem, or heart symptom in 60%, 35%, 25% of cases respectively. Then there are these associated conditions and triggers. So as I said, in about 60% of patients is primary, while in the remaining, there could be these associated conditions of triggers in the form of autoimmune diseases, infections including HIV, cancer, pregnancy, drugs, transplant, and this. When the platelet count goes very low, there could be bruising and there could be bleeding. So acute symptoms of TTP include seizures, stroke, cardiac failure, renal failure, and bleeding. Long-term manifestations include neurological symptoms, cardiovascular symptoms, renal symptoms, and there could be recurrent episodes of TTP. And the chronic cases could have subtle symptoms like headache, GI pain, or brain fog. Let's come to the diagnosis of TTP. Well, it's extremely important to investigate this properly to diagnose TTP. On clinical grounds, you can only suspect, not diagnose. So lab investigations include cystocytes, which should be more than 1%. Less than 1% is a bit non-specific, which can happen due to difficult collections. Evidence of hemolysis as reticulocytosis, indirect hyperbilirubinemia, almost absent haptoglobin, and raised LDH. But mind you, the raised LDH is a major marker of tissue ischemia rather than just hemolysis. The Coombs test should be negative. The coagulation parameter to differentiate from DIC should be normal. So when kidney is involved, there's proteinuria, hematuria, raised creatinine, cardiac trop could be more than 0.1, ECG changes, and then, of course, sine is documenting ADAMTS activity less than 10%. And then in acquired cases, look for the autoantibodies. It's present in 3 out of 4 cases. In genetic cases, go for the gene sequencing. So that's the flow diagram of investigating TTP. When you're suspecting a thrombotic microangiopathy, ideally order for the ADAMTS13 activity. If it's more than 10%, forget about TTP, search for the diagnosis. It's less than 10%, it is TTP. And look for the antibody, and if it's positive, it is autoimmune acquired TTP. And if it's negative, then you look for the ADAMTS activity in remission and also look for antibody during relapses. If the ADAMTS activity is low and antibodies are detectable, it again confirms autoimmune TTP. If the antibody is always negative, it could be acquired TTP of unknown mechanism. And if the ADAMTS level is always less than 10% and the antibody is always negative, it's likely to be the genetic mutation. If genetic mutation is found, it is a definite case of inherited TTP. If it's not found, it could be TTP of what is called unknown etiology. There are ISTH guidelines for diagnosing TTP. And molecular diagnosis is quite vital for the accurate classification, as you must have seen by now, to differentiate acquired in children and to diagnose genetic in adults. You must have heard of a very simple formula called plasmic score. Plasmic score is extremely useful in suspecting TTP and starting plasma exchange in emergency, even before you have the levels of ADAMTS13, or if you do not have facility to do ADAMTS13 levels. So plasmic score is to help decide on benefit of plasma exchange, which is a savior to be offered to suspected cases of TTP, which are not yet diagnosed by doing the ADAMTS13 activity. So there is a score of 0 to 7. Platelet count should be very low, and that gives you a score of 1 below 30,000. Creatinine should not be more than 2, and that gives you a score of 1. INR should not be significantly high, so that gives you a score of 1. MCV should not be high. There is a genetic variant where the MCV is high because of cobalamine pathway abnormality. Presence of hemolysis, reticulocytosis, or undetectable haptoglobin, or indirect hyperbilirubinemia, all together there is a score of 1. Absence of active cancer, score of 1. And no prior stem cell or organ transplant, score of 1. So total score of 7. You don't see cystocytes over here because that is the starting point. No cystocytes, you do not apply the plasmic score. So if the plasmic score is high, 6 to 7, well, you order for the ADAMTS 13 level, but straight away go for the plasma exchange. If the score is 5, you order for the ADAMTS 13 level, and maybe you give just plasma and not plasma exchange. If the score is 0 to 4, you send ADAMTS 13 level, but do not give plasma or do not do plasma exchange. The idea is to avoid unnecessary plasma or plasma exchanges. This score has been externally validated also. This is a study from US. There's another one called French score, which is not very popular, but even simplistic. It just has 3 points. If creatinine is not very high, 1 point. The platelet is very low, 1 point. The ANA is positive, 1 point. And if you have a score of 2 to 3, that's a high score indicating immediate plasma exchange. What's the differential diagnosis of this entity? By now you must have understood that TTP has a differential diagnosis in the form of hemolytic uremic syndrome, the classical one, the atypical one, which is due to complement alternate pathway abnormalities, other thrombotic microangiopathic syndromes, including HELLP during pregnancy, and one should be careful as adults Evans syndrome could also present with thrombocytopenia and hemolysis, but this is a Coombs positive, spherocytic or agglutinated RBCs. All this is important because plasma exchange will not help in MAHA if there is no TTP. This is a case report SLE with TTP where the SLE was quiescent. So you have to be careful. Hemolytic uremic syndrome, as you know, is secondary to the toxin produced by E. coli, which is secondary to the infected food. A major difference in HUS from TTP is that in HUS, renal dysfunction is very severe. There is hemolysis and some amount of thrombocytopenia. While in TTP, the renal dysfunction is not severe, the thrombocytopenia is severe, and there are neurological manifestations with fever. So hemolytic uremic syndrome, ingestion of infected food leading to abdominal pain, diarrhea, fever, and vomiting. It can be bloody diarrhea in 90% of patients. You do culture, you get positive culture, diarrhea settles. The disease spontaneously resolves in majority, but leads to HUS in 15%. So that is a flow diagram for hemolytic uremic syndrome, which I'm not going to go in today. And then atypical HUS, which is essentially due to abnormalities or mutations in complement regulatory factors. Once again, we are not going to go into the details of this, but an atypical hemolytic uremic syndrome is due to various kinds of complement mutations, and you may not have easy access to diagnose this entity bedside in majority of the countries. So hemolytic uremic syndrome could be typical, stack and stack-like, atypical, complement alternate pathway, and secondary due to various causes that we talked about in the beginning of my talk. A new entity today is the COVID-19 vaccine-induced immune thrombotic thrombocytopenia. Again, we don't have time to discuss this, but you should be aware of this. I'll just show you some cases for making this matter a bit more simplistic. So we'll take a hypothetical patient here, Sapna. It's a disease of young women. 21-year-old Sapna had headache, confusion, dysarthria, seizure. It started suddenly and the MRI showed infarct. This may look like a neurological problem, but the CBC showed anemia and low platelet. Anemia was hemolytic, and the hemolysis was with RBC fragmentation. This was enough to diagnose TTP. ADAMTS 13 level were ordered, but patient was immediately put on exchange, plasma exchange. Finally, Sapna was cured. Here is Sapna having acute abdominal pain, nausea, vomiting, diarrhea. Imaging showed bowel ischemia. Once again, lab showed hemolytic anemia, RBC fragmentation, thrombocytopenia. She was given plasma exchange, and finally she was cured. And here is Sapna having chest discomfort, hypotension, ectopics, ECG changes, height drop. same parameters, TTP diagnosed, exchange done, she's cured. So what you saw is our hypothetical character had either brain or GI or heart problem. These are common due to many other conditions which are hundreds-fold more common than TTP, but our CBC showed fragmented RBC and low platelet. And that made one suspect TTP, and therefore emergency plasma exchange was done, saving 90% of the patients. What is the prognosis of TTP? Well, prognosis could be good, bad, or ugly. Good is patients may get cured. Bad is the patient may get relapsing. And dirty is that the patient may die. So we come to the management. So treatment should be done because 90% of the patients become well and the mortality can be reduced to less than 10%. Management includes emergency plasma exchange or plasma infusion, or it's called plasma therapy. This is to remove those large multimers of von Willebrand factor, and plasma exchange is to supply ADAMTS in addition. But the root cause is immunological, so you need immunomodulation, and that's done with steroid and rituximab in virtually all the patients. In refractory cases, you use other immunomodulators, and we'll talk about two novel treatments, that is caplacizumab and recombinant ADAMTS-13. So the most important emergency treatment on Saturday night, Sunday, holiday, any time, the moment you suspect that this could be TTP on definite grounds, even before the ADAMTS-13 level comes to you, start plasma therapy in the form of plasma exchange, and if that's not available, plasma infusion. Plasma exchange is nowadays available at a city level all over. With the help of nephrologists, we do it any time of the day or night, and it is superior to plasma infusion, was shown almost 30 years ago. So urgent plasma exchange and all the techniques have been published repeatedly for the last 30 years. Plasma pheresis will delay other interventions if the patient didn't have TTP. So please be sure that you are in the cup of TTP. Immunomodulation with corticosteroids started on day 1. Any kind of steroids in usual doses, and then tapering them as the patient responds. They continued for a few weeks to few months. Rituximab has become a mandatory component of treatment of this entity today, and if you do not use it early, if at all the patient shows relapse in the form of platelet dropping, LDH going up, and you use it, patient again settles down. Refractory cases, I talked about other immunomodulators, and these could be bortezomib, vincristine, cyclophosphamide, cyclosporin, or N-acetylcysteine. So this is bortezomib, a promising alternative to refractory relapsed TTP, where rituximab failed. That's vincristine. That's another vincristine. This is cyclophosphamide. This is cyclosporin. That's cyclosporin. That's N-acetylcysteine. All of these have been used when you're pushed against the wall. The advances in the treatment of TTP is caplacizumab. Caplacizumab is also a monoclonal antibody like rituximab, but it is not against CD20. It acts at the level of von Willebrand factor and platelet interaction. So it blocks the interaction between these multimers with platelet, so the thrombi do not occur. So that's something fascinating and a new drug to you. So you make a clinical diagnosis of ITTP, immune TTP, platelet count is less than 30, creatinine is not very high, ADAMTS has been sent. You start this patient on plasma exchange. If the ADAMTS level comes and it is less than 10%, you start caplacizumab, 10 milligram daily, and it's given continuously. You keep monitoring the levels of ADAMTS-13 once every week, and they will keep improving. If the French score is more than 2, you can start rituximab straight away once a week for 4 doses. If the French score is not so high, you can wait for the ADAMTS level and then add rituximab. In many parts of India, you may not get the results of ADAMTS13. Even though standalone labs are doing it for you, they take time, and you may have to start rituximab empirically. Triple regimen is the terminology used for mandatory plasma exchange, mandatory immunomodulation, and addition of carfilzomib to doing only plasma exchange, corticosteroid, and rituximab. As you see that the triple regimen over here is far superior to historical control. P-values are all significant with respect to death, refractoriness, exacerbations, time to durable platelet recovery, number of daily plasma exchange until remission, volume of plasma needed to achieve remission, time for the ADAMTS13 activity to become more than 20%, and the length of hospitalization. All these were significantly better than if you use only two regimens, that is plasma exchange and immunomodulation. So that's cumulative hazard of recovery, much better when you use triplet than the historical control. And this is once again in blue, the triplet versus red, the historical, and this is cumulative percentage of patients who achieved ADAMTS13 level more than 20. So it happens much earlier if you use carfilzomib. Triple regimen with carfilzomib, immunosuppression, plasma exchange prevents unfavorable outcome in high TTP. The question is then, should all patients of high TTP receive carfilzomib? Is it cost effective is the question that is asked, because it's one of the very expensive drugs. And this is some sort of calculation. So high is the cost of carfilzomib that even Western world thinks about it before using. There are certain things which should not be done in the treatment of TTP. One is platelet transfusion. Platelet transfusion will lead to increased ischemia because that is a part of pathogenesis. Unless the patient is dangerously bleeding, platelet transfusion is not given. And the second is the historical treatment of touching the spleen, that is doing splenectomy. We used to do that 20, 30 years ago, but with steroids, rituximab, plasma exchange, today we don't do this. So these are milestones in the management of TTP from 1924 to 2022, almost 100 years. From first case reported in 1924, steroid therapy, plasma therapy, ultra-large von Willebrand factor, role of plasma exchange, ADAMTS13 antibody, rituximab, bortezomib, and carfilzomib, Titan Herculean trial, and finally recombinant ADAMTS13 for congenital TTP. So this is the whole sort of gamut of treatment protocols that are available to you. Therapeutic plasma exchange is most important. Steroids, rituximab as immunomodulation are universal. Carfilzomib in the Western world, and recombinant ADAMTS13 for genetic or mutated disorders. That's sort of again a diagram giving you all about treatment of ITTP, daily plasma exchange, daily steroids, daily carfilzomib is possible. Not available, rituximab becomes a must. Patients managed in ICU, search for the trigger, search for predisposing condition, give cardiac protection. Response occurs, patient goes into complete remission, follow up this patient, avoid triggers, monitor ADAMTS13. If it is dropping, give preemptive rituximab and search out for the late effects. In refractory cases, you may have to use other immunomodulation, double plasma exchange, higher volume, twice a day, increased doses of steroid, even more frequent rituximab, and adding carfilzomib and other immunomodulators that we talked about. You should be smart. You should give optimum treatment and not maximum treatment. So you should know when to stop. Platelet normalize, LDH drops, another 2 days, and you should stop plasma exchange. Taper the steroids and stop rituximab. So the good practice statements, GPS for the clinical care of patients, published by Flora Pevandi, a champion of TTP. And this is James George writing this article, TTP from 1972 to 2022 and beyond. There are wonderful books on TTP. 3 of them are shown here. Have them in your library or your shelf. What's the future of this entity? The future is, can we get rid of this complicated plasma exchange? And this is the vision. Caplacizumab with rituximab, simple and safe, could be the master blaster. And James George writes this editorial, TTP, the evolution of clinical practice. And the last part is, the future could be simple and safe, just two monoclonals, caplacizumab, rituximab, and no plasma exchange. To summarize my talk this day, these patients have severe thrombocytopenia. They have MAHA, that is microangiopathic hemolytic anemia, that is RBC fragmentation, cystocytes. There is organ ischemia. There are disseminated microvascular platelet-rich thrombi involving arterioles and capillaries. There is severe deficiency of ADAMTS13, less than 10%, which is the only specific biological marker. Usually it is acquired due to autoantibodies in 90% of cases, and rarely it is inherited in 10% of patients. Essentially a disease of adults, females outnumber males, obese and blacks in US. Acute onset, but often a relapsing course. Treatment, daily plasma, therapeutic plasma exchange, steroids, weekly rituximab. Refractory cases, bortezomib, cyclophosphamide, vincristine, cyclosporine, and if you are pushed against the wall, splenectomy. New drugs include caplacizumab and recombinant ADAMTS13. Long-term follow-up is important to predict the relapses early, to give prophylactic rituximab, to identify other autoimmune diseases, and there can be long-term psychophysical sequelae to the extent there is increased suicide rate in these patients on long-term follow-up. In conclusion, there are certain learning points, and I would like to tell you 10 things that you must not do. Do not miss the diagnosis of thrombotic microangiopathy. Do not consider all TMAs as TTP. Do not skip looking at the peripheral blood film for the broken RBCs. Do not miss the diagnosis of mild hemolysis where bilirubin is 1.3, reticulocyte count is 5, haptoglobin is 20, LDH is 500. Do not miss subtle signs of organ dysfunction. There may be trop eye, there may be MRI changes, there may be proteinuria, and so on. Do not hold plasma exchange awaiting for the final diagnosis. Don't forget to collect the blood before doing plasma exchange for ADAMTS13. Always differentiate immune TTP from congenital TTP. Do not forget to look for the trigger factors, and do not avoid long-term, which may be lifelong follow-up. These are the 10 things which are important. So thrombotic microangiopathies, rare diseases, but that's our focus, expertise, and passion. You may say, what's there in name? Rose is a rose, whatever you may call it, but I think name has a power. So if you've got a TMA, it should be diagnosed to be TTP because that gives you the line of treatment. This is a doctor, a hematologist, a young hematologist who diagnosed TTP in this lady and saved her life, and today they form a couple. Happy days are here again. I think we have a great victory in decreasing the survival of TTP patients from 10% to 90% in a century. Thank you so much. Do remember to visit the website of Mumbai Hematology Group. Very simple, www.mhg for Mumbai Hematology Group, mhgindia.com. So www.mhgindia.com. The questions, it will be my pleasure to discuss. Thank you so much for listening to this talk. We will be taking actually questions after the second guest lecture, and we have about 9 minutes in between. So what I plan to do is to give you the answer to the quiz in these 9 minutes, and by that time Dr. Sonavala will be with us and she will give her lecture, and then we will take all the questions together. So coming to the quiz that was put to you, it was related to hepatosplenic T-cell lymphoma. You were shown 11 statements, only one of which was true. And you were to name, you were to send the number of that true statement to me. And these were the statements. If you remember, The hepatosplenic T-cell lymphoma accounts for 15% of peripheral T-cell lymphoma, common at elderly age, more common in female. Besides liver and spleen, there are lymph nodes. There are B group symptoms, very rare. Cytopenia, rare. Hemophagocytosis, rare. Histologically, sinusoidal pattern, rare. 80% alpha beta type. Inflammatory bowel disease and the treatment of chemotherapy or biological agents increasing its incidence, and the transplant not recommended. These were the statements made. Okay, tell you something about hepatosplenic T-cell lymphoma. So when you're talking about mature T-cell lymphomas, these could be nodal, extranodal, skin, and leukemic. Today's subject is over here, extranodal peripheral T-cell lymphoma, the hepatosplenic T-cell lymphoma. And if you look at its incidence, it's over here. It's 1.4% of all the T-cell lymphomas. The PTCL, angioimmunoblastic being the two commonest. Patients present with massive hepatosplenomegaly, and that's hepatosplenic T-cell lymphoma. And that's one of the PET scan, and that's one of the removed spleen. Majority of them, 80% are delta, gamma delta type, not alpha beta. So in short, hepatosplenic T-cell lymphoma is a rare, aggressive extranodal lymphoma. It is derived from cytotoxic gamma delta T cells. It's a disease of young people. Median age is 38. It's more common in males. 20% of cases arise in the setting of chronic immune suppression, most commonly solid organ transplant or prolonged antigen stimulation. The patients typically come with B symptoms. In 3 out of 4 patients, there is fever, weakness, etc. There is hepatosplenomegaly, but lymphadenopathy is virtually absent. Patients usually manifest with marrow failure in the form of thrombocytopenia, which can be marked, anemia, leukopenia. There could be a leukemic phase, and the marrow is involved in almost 80% of cases. Spleen is always enlarged, liver is enlarged in half the patients, lymphadenopathy is very rare. The routine lab shows you elevated LDH in 3 out of 4, liver dysfunction in half, and decreased fibrinogen in 1/3. It exhibits a marked chemoresistance to the available treatment, rapidly progresses, and the outcome is dismal. Standard treatment is not yet established. We invariably give anthracycline-based treatment. There is satisfactory response in 2/3, but the poor long-term results. Complete remissions are very rare. Most patients die from lymphoma within 2 years, and upfront allotransplant is recommended in all transplant eligible patients. And being a disease of young people, it's possible in many. This is a summary. Cytopenia, constitutional symptoms, liver spleen, and phagocytic syndrome are often the clinical presentation. Sinusoidal pattern on morphology, atypical cell, erythrophagocytosis are common. The phenotype is gamma delta, and the treatment is you give induction therapy followed by allogenic transplant. So, friends, the correct statement was one single, and that is inflammatory bowel disease and its treatment leads to increased incidence of hepatosplenic T-cell lymphoma. All other statements were wrong. So 10 was the answer expected. Almost 50 of you have sent the answer, and 7 of you are correct. This is from 2nd to 7th, between 11:48 to 11:54. And the correct answers and congratulations to all of you in the order in which we received them is Dr. Sumit Mirk, Dr. Pujita Reddy, Dr. Bilal Kazi, Dr. Satish Kumar, Dr. Radhika Shetty, and Dr. Nishad Dakate. And the fastest finger first and heartiest congratulations is Dr. Ketan Modak. I'm not sure, but probably you are still senior resident doing your DM clinical hematology at CMC Ludhiana. And if you have finished that, then you must be a faculty there by now. So congratulations to you. Send us your bank details and you will have your prize money transferred within a week. So congratulations to you, and I'll stop this quiz over here. And Dr. Ayesha has joined, so it's my pleasure now to introduce her, and I'll do that in a second.
Sir?
Yeah. Just a second, huh? Just a second. Can you see my screen?
Yes, sir.
Okay. So our guest speaker for the second lecture is Dr. Ayesha Sunawala, ID specialist from Mumbai. She's going to speak on interesting hematology ID cases with management issues. She is DNB medicine, FNB infectious disease specialist at PD Hinduja Hospital Medical Research Center, Mahim. She's consultant division of infectious diseases, PD Hinduja, Mumbai from December 2017. She's head the National Board Accredited Infectious Disease Fellowship Program at Hinduja. She's secretary of Antimicrobial Stewardship Committee, mentor and course coordinator, Hospital Fellowship in Infectious Diseases and Antimicrobial Stewardship. She will speak to us on this subject, interesting hematology ID cases with management issues. So over to Dr. Ayesha.
Thank you, sir, for that kind introduction, and more so for having me here today. It's an honor to be invited to this epic meeting. So I'm going to start with my cases. Okay, I hope you can see my slide.
Yeah.
It's visible.
Yes, visible.
Great. Okay. Okay. So patients with hematological diseases are often at the far end of the spectrum. That is the very abyss of immunocompromise. And yet infections in these extremely vulnerable patients can be very deceptive, like you're seeing them through a smoke screen. They have atypical presentations, they have a varied clinical course, there may be more than one opportunistic pathogen at a time or in the course of things, and hence management strategies must keep in mind the ever fertile terrain of these hosts. So today I've thrown together a medley of cases that we have struggled with and hopefully emerged wiser from. And I've speckled my presentation with a lot of questions, only to generate an interesting discussion between us. Understanding fully well that really in many of these cases, there are no correct answers really. So I'd appreciate your views. And Dr. Agarwal, sir, can we sort of have a discussion while the cases are going on with the delegates?
No problems.
Okay. So the next two cases actually depict one of the few conditions in infectious diseases where, like cardiology and neurology, there should be golden hours in treatment. Because the timely sort of clinical suspicion, appreciating the signature pattern of these infections and early empiric initiation of appropriate treatment really can change the trajectory of these infections. So I'll start with my first case. This was a 40-year-old lady, chronic kidney disease from Mumbai. 2010, she had cervical lymph node TB for which she was treated. And the year later, she underwent a living-related renal transplant. She was on triple immunosuppression. Her creatinine was, baseline creatinine post-transplant remained around 2.5. About 7 years post-transplant, she was admitted with a progressive frontal headache and weight loss of over 6 kgs in 2 months. There was no fever, no meningeal signs, in fact, no constitutional symptoms at all. And there was no recent augmentation of immunosuppression or any recent travel history. This is what her MRI looked like. And you can see a large sort of lesion here with significant perilesional edema. This lesion in the left parieto-temporal was about 4 by 2 centimeters, a smaller lesion in the right frontal. So I said significant perilesional edema, and the radiologist had made a sort of a radiological diagnosis of an opportunistic infection in this immunocompromised patient. So we're all very well aware of this timeline in post-transplant infections. And looking at that she was way past the 1-year mark, these were the several differentials that we kept in mind. Again, knowing that this patient had no constitutional symptoms apart from the weight loss, and that she had no leukocytosis, nothing else to really suggest an ongoing active infection. What would you do next? Would you start her on empirical anti-tubercular treatment? She's had a history of TB prior to the transplant. Do you want to start empiric anti-toxoplasmosis treatment for 14 days like we do in our HIV patients with CNS lesions and significant perilesional edema? Do you want to check her CMV viral load, a whole body PET to look for additional areas of involvement, CSF, stereotactic brain biopsy? I'm happy to sort of have any inputs either on the chat or even if someone would just like to turn on their speaker and talk.
So audience can put the answers, and those faculty who are present over here, please go ahead. Let's have an interactive session.
I would opt for a stereotactic brain biopsy, sir.
Okay.
Shruti?
I would opt for a PET CT scan to look for additional areas of involvement, because given the status, like she's bad, she has only weight loss, no constitutional symptoms. My differential would be EBV-related PTLD here. So I would like to do a PET scan and look for additional areas of involvement. Also CSF may help, but after reduced ICT, like we do all the measures to reduce the late ICT, and then we can go ahead and do a CSF. And CSF flow cytometry is also very important. Apart from all other infectious things, flow cytometry in the CSF is also very important.
Varun?
Sir, yeah, I think first CSF we will do, and then we have to send the infectious panel. If we rule out infection, then I think we'll work up for malignancy. Then we can go for brain biopsy also.
Okay, anybody else? Right, you have few answers, Aisha, go ahead.
Right. So some very pertinent answers over there. And this is how we thought. Empiric treatment in a stable immunosuppressed population is really counterintuitive. These patients often don't allow us the leisure of trial and error. CMV viral load makes little sense over here. As I said, no constitutional symptoms. This is not a CMV syndrome. And if this was an end organ CMV, then plasma CMV viral load is very poorly sensitive, especially for the CNS and GI variants. A whole body PET we did do to look for additional areas of involvement, and there were none. It was only limited to the CNS. We chose not to do a CSF in this patient because there were really no meningeal signs, no fever, nothing else. And the neurosurgeon was quite keen to, go ahead and take her up. He said that it was the frontal lesion was really quite superficial, and he would be able to do a stereotactic brain biopsy quite easily. And so that's what we went ahead and did. And as one of the faculty pointed out very correctly, there were large atypical lymphoid cells with there are large areas of necrosis and hemorrhage. The immunohistochemistry was positive for CD45, CD20, BSL2, MUM1, and the lymphoid cells strongly expressed EBV. So this was really, as she pointed out, this was a post-transplant lymphoproliferative disease. And we know that the principal risk factors here are the degree of T-cell immunosuppression, EBV, a serological status of the recipient, time post-transplant, the recipient age, ethnicity. This child had adopted a school-going age, adopted a child who was of school-going age. Could this be primary EBV that we were looking at?
So question for everybody.
Or we could go on. So what we could find was that primary EBV infection tends to present in the first year post-transplant with a febrile mononucleosis syndrome. And after that, you have the bimodal typical pattern within the first year and then beyond 5 to 7 years. She had some negative prognostic indicators. She had CNS disease. She had the monomorphic variant. We know that EBV serology in these immunosuppressed patients is really not very helpful at all because they often delayed the titers. The EBNA titers may fall in seropositive hosts with the onset of PTLD. And really, tissue histopathology is the gold standard. So that was done, and this patient was treated with rituximab and temozolomide, and her immunosuppression was reduced. About 4 months later, she had progressive breathlessness, dry cough. She desaturated. She was afebrile at this time. We weren't involved so far. This is all in hindsight. There were pulmonologists who were involved, and they did a bronchoscopy. They ruled out any infective etiology. And finally, they made a diagnosis of rituximab-induced interstitial lung disease. And she was treated with high-dose steroids. She came in a month later, admitted into the ICU with high-grade fever, cough, drowsiness. She was in diabetic ketoacidosis, probably steroid-induced. Her counts were raised, significantly raised, at about 28,000. She had acute kidney injury on the CKD. Creatinine jumped from 2 point something to over 4. And her blood and sputum cultures were showing a methicillin-susceptible Staph aureus, for which she was started by the ICU team on injection flucloxacillin. And you can see over here in the CT scans that you have a typical sort of nodular consolidates and necrotizing pneumonia. What would you do next for this patient? Would you continue flucloxacillin for the MSSA bloodstream infection with the necrotizing pneumonia? Do you want to do a bronchoscopy or a CT-guided lung biopsy? Do you want to send off a 1,3-beta-D glucan? Or would you start empirical anti-mold treatment for this patient?
Anybody?
Usually we do a bronchoscopy, send a galactomannan test, and start a empirical anti-mold treatment for such patient.
Sure. In these patients who are in the ICU, often bronchoscopy, CT-guided lung biopsies are practically not possible. In the ideal setting, yes, by all means. In fact, for peripheral lesions like this, even a CT-guided biopsy would be perfect because you would be able to go into the lesion and get what you want. Anyone else?
In that case, I think we can start empirical anti-mold treatment.
Is there any reason why you want to start empiric anti-mold treatment? I mean, can you justify that?
Yes, this CT pictures, I have a feeling that it is not just a bacterial something. I've got like, it looks like some fungal like etiology could be there.
In fact, if we look at this CT picture over here and even the one previous, you can see that there's an area of central necrosis, and this is the very ominous or sinister reverse halo sign that we talk about. So you're absolutely right that, of course, we can't deny that she had a bloodstream infection. She had sputum, both with the same organism, Staph aureus. Staph aureus can also cause necrotizing pneumonia. There's no doubt about that. But in this patient, post-PTLD, with the high-dose steroids given for the rituximab, who presented to us with diabetic ketoacidosis and this new onset, cavitatory necrotic lung nodules, definitely we would want a diagnosis, and we'd very strongly suspect a mold infection. But unfortunately for her, bronchoscopy was not possible at the time. She was tachypneic, she was hypoxic. The pulmonologist refused in these kind of patients. She was too unstable to be taken to CT for a CT-guided biopsy. What do we know about the 1,3-beta-D glucan? Yes, it would be helpful if this was aspergillus or any other septate fungal infection. We know it's a pan-fungal marker, except for mucormycosis, cryptococcosis, and blastomyces, wherein it wouldn't be positive. And mucor would be an important differential over here, especially with that reverse halo that we saw on the CT. So that's what we did as well when we came in. But that was about 72 hours later. So 72 hours later, she developed chemosis and proptosis of the left eye and a partial loss of vision. And there was a rapidly involving right eye involvement as well. And that's when she was referred to us and we threw in the anti-mold cover. So you can see the sort of CT showing us features of pansinusitis with bilateral orbital cellulitis. There was no bone erosion as yet. But this is when the ENT people actually went in bedside and got us some samples. And you can see the calcofluor stain showing you broad aseptate or pauciseptate hyphae with right angle branching, very suggestive of mucormycosis. And we now have the means to speciate our mucormycosis. And here we have a Cunningham. We can even do an antifungal susceptibility test, which we could never do. This is all very recent in the past couple of months only. And you can see on the antifungal susceptibility testing that the MICs are rather high for this species with an amphotericin B MIC of 4. So what do we know about this subspecies of mucormycosis, Cunningham? And how would you treat this disseminated infection in the lungs and in the sinuses, in the orbits? So this was a review, large series of mucor in which about 2.5% were found to be Cunningham. And we know that this species is more commonly cultured from pulmonary or disseminated mucormycosis. And although amphotericin B really demonstrated the most potent in vitro activity across all genera, it was with the exception of Cunningham for which the MICs were much higher. And if you look over here, not just the MICs of amphotericin B, but even isavuconazole are much higher for this species of mold. So the activity of isavuconazole is also markedly lower against Cunningham, mucor, and another species called syncypalastrum. So these are things that we're learning as we go along and things to keep in mind, and the importance of being able to speciate mucor and get a resistance test now on it. So this patient was treated with a combination of high dose liposomal amphotericin B, and we threw in IV posaconazole when we got the speciation. The unfortunate procedure of bilateral orbital exentration was discussed with the family. And of course, given what she had gone through, they were diffident to go ahead with this. And unfortunately, the disease spread or disseminated really dramatically over the next few days, and she succumbed like we've seen so many of our disseminated mucormycosis. We note that the statistics stand at over 60% mortality in disseminated mucormycosis despite surgical and medical management, optimal surgical and medical management. So with that, let's go to the next case, and one that was really at a different end of the spectrum, which is why I'm showing it here. A young male, Mumbaikar, no comorbid conditions. This was May 2020 at the height of our first peak of first wave of COVID, who came with intermittent gum bleeds and sore throat, diagnosed as aplastic anemia. He was started on cyclosporin and a thrombopag with the prophylaxis of valacyclovir, TMP-SMX, and voriconazole by the hematologist, and he was referred for an allogenic hematopoietic stem cell transplant. It was early September. The stem cell transplant was deferred because of logistic and monetary constraints. He had progressive pancytopenia, and so anti-thymocyte globulin was administered. He developed high-grade fever and rash after administration of ATG, and he had a high procalcitonin. He was put on oral steroids, but meropenem was also added empirically. And we know that elevation of PCT is known in patients receiving ATG, and it may not be indicative of sepsis. But nevertheless, empiric antibiotics, broad spectrum antibiotics are always added in these patients until you have negative culture. So 10 days later, this patient was readmitted with high-grade fever, chills, had developed a perianal abscess, had dysuria. You can see the urine culture showing a carbapenem-resistant pseudomonas, and that's when we actually came in. And based on the culture report, we started this patient on carbapenem, CR cover, so ceftazidime, avibactam, astrinum, And we switched the voriconazole to posaconazole because he had profound prolonged neutropenia. And we wanted a more broad spectrum mold cover. Unfortunately, like so many other patients at that time who were hospitalized and undergoing treatment for something else, this patient probably acquired nosocomial COVID and was detected COVID positive and shifted to the COVID isolation ward, where he spent the next 20 days. He received the usual COVID treatment, remdesivir. He had recurrence of fever spikes while he was there. Cytopenias were ongoing. Perianal pain, for which he finally underwent an incision and drainage while he was in the COVID isolation facility. And you can see from the pus in the sort of perianal abscess, there was a pseudomonas again with a different susceptibility over here and an enterococcus. He had settled down and we de-escalated to piperacillin tazobactam. Now, unfortunately, the posaconazole was stopped at that time in the COVID ward because he had a lot of GI intolerance. And with all the other things that were going on for a couple of days, perhaps a little more than a couple of days, 4 or 5 days, the posaconazole was withdrawn. This is day 11 in the COVID ward. It was a Sunday afternoon and we were taking rounds. When he developed intermittent fever spikes, the day after, when we were there, he complained of jaw and gingival pain. And about 6 hours later, we noticed that there was swelling and numbness over the right half of the face. Numbness or paresthesia is really a very ominous and yet a very pathognomic sign of mucormycosis, which affects the cutaneous nerves. So our antennae were up. You can see this swelling that has appeared in the periorbital region, very minimal, no affection of vision at all. And we knew that this was very difficult logistically. We were in the COVID ward. It was a Sunday afternoon. It would be very difficult to mobilize teams. And so we decided to hit him with empirical liposomal AMP4 within the first 12 hours of symptom onset. And we said, if we don't find anything, we'll switch back to POSA or whatever other mold prophylaxis and see what to do. But this is what I mean by an effective multidisciplinary coordination and the golden hours. So that suspicion of the risk factors, the characteristic clinical clues, the signature pattern by either a physician, ID specialist, intensivist, oncologist, hematologist, endocrinologist is really the first trigger that sets this path in motion. And if you can't get the rest going in the next few hours, then empiric antifungals are definitely the way to go. You corroborate your clinical suspicion as soon as you can with the radiologist and the ENT specialist. If you find that this is consistent, an urgent tissue diagnosis with an intra-frozen section involving a pathologist, remembering that you need ample tissue specimens, not swabs, not specimens from the eschar, but specimens from the viable areas abutting the necrosis. So you can see vascular invasion and you can see the morphology of the fungus. And while this is going on in the OT, there needs to be very sort of clear communication with the lab that you're suspecting mucor. Please do not grind the specimen, do not homogenize it, cut it so that we have the characteristic aseptate pattern, and discussion with the histopathologist to confirm the angioinvasion. So as I said, we had myriad challenges at that time. This disciplinary coordination was very difficult. This patient had severe thrombocytopenia, and so there were procedural challenges. And in 2020, during the first wave, you have to remember that we hadn't yet seen the second wave of COVID and all the mucor that we had. So this was only the second case of COVID-associated mucormycosis. I even wonder whether it was COVID-associated. This patient had other risk factors for it. So I really don't think the COVID, it was a mild COVID. I don't think it had a large role to play over here. But as you can see, his CT scan was really very characteristic. The first sign of orbital extraocular muscle thickening and panfungal sinusitis here. And in this patient, this was the only patient where we administered the amphotericin B at the bedside. And because it was given really within the first few hours of symptom onset, he actually said that the numbness and paresthesia reduced during the 4 to 6 hours of amphotericin B administration itself. And you can see a complete reversal in the facial and periorbital swelling in the next 48 hours. no diplopia, vision, and the extraocular movements were absolutely intact. This was 10 days later. You can see a marked difference in the thickening of the extraocular muscles. We continued on liposomal amphotericin B. He remained anemic, thrombocytopenic, and transfusion dependent. This was in December 2020, couple of months later, where we had completed 6 weeks of liposomal amphotericin B, and we switched to isavuconazole because he had posaconazole intolerance. His CBC is normalized after stopping the liposomal amphotericin B. And I mean, this could have been a late reaction to the antithymocyte globulin, but having said that, we have seen cases of cytopenia induced by liposomal amphotericin B. And remarkably, 6 months later, he had completed 6 months of treatment. He had complete clinical and radiological resolution, and he remains transfusion independent till today. So this was really a sort of marked difference from what we saw in the first case. And that brings me back to the golden hours in the management of invasive mucormycosis in the hematological patients. This very interesting study, which showed that if we initiate amphotericin B-based therapy more than 6 days after presentation, it resulted in 2-fold increase in mortality at 12 weeks after diagnosis. And this was an independent predictor of poor outcomes. So this patient was lucky that he was hospitalized. He was under our observation in the COVID ward. But just imagine what we could change this figure to if that 6 days was reduced to 6 hours. We would definitely attenuate tissue injury and angioinvasion, reduce the probability of contiguous and hematogenous dissemination, disfiguring, debilitating surgical resections in these patients, and most importantly, improve outcome and survival for certain. So with that, I'm going to move on to the next 2 cases. And these 2 cases were about really looking beyond the blood work. We often find ourselves so dependent on lab support, and especially us with infectious diseases where we rely on our rapid molecular tests and our cultures and serology and what have you. But sometimes all of that can actually prove misleading, and we find our clues and our answers in the patient's case sheets themselves or in their histories, like this patient here. So this was a 39-year-old gentleman, case of multiple myeloma, who underwent an autologous hematopoietic stem cell transplant. He was on ceftriaxone and acyclovir prophylaxis. Post-transplant day 10, he developed fever spikes. He was empirically started on meropenem and teicoplanin by the primary team. Blood and urine cultures were sent. So this was his urine culture. You can see there's again practically pan-resistant E. coli and a Proteus vulgaris. They had even done a molecular test to see what the carbapenemase pattern was, and we had an NDM plus OXA-like carbapenemase production. And we were actually called in at this point for an ID reference for the urine culture. This patient had no dysuria. Urine routine showed about 8 to 10 pus cells and 3 to 4 squamous epithelial cells. He was hemodynamically stable. Chest X-ray was normal. The question now is, how would you treat this infection? Do you want to give this patient colistin? We know that Proteus vulgaris is inherently resistant to colistin, and you might want to add a fluoroquinolone instead of a penicillin group because this is a spice organism. So would you like to give colistin plus ciprofloxacin, Zavicefta plus aztreonam, colistin plus fosfomycin? I'm not putting in polymyxin B because we're looking at a urinary tract infection here, or you're not convinced of a UTI. Does anyone have any other suggestions or anything from this?
Yes, faculty here, please. Okay, nobody wants to respond. Go ahead.
Okay. So this is difficult because here you have a transplant patient who is running fever, who is cytopenic, in whom you have a culture which is positive, and yet you're not convinced based on his symptoms, based on the urine routine. Of course, you'll repeat the urine routine, you'll repeat the culture, you'll see that it's sent properly. But what do you do in the interim? And this is something that we always look back on, and this is what we corroborated from his charts. If you can see, the fever spikes coincided with the day of neutrophil recovery in this patient. This is WBC count here. And this patient had no other localizing symptoms. Again, this is a pathognomic clue to a certain.
Probably engraftment syndrome.
Okay. So how would you clinch the diagnosis? Do you want to do a liver function test? Do you want to do beta-D-glucan? Do you want to check blood cultures? Do you want to do an abdominal imaging?
So chest X-ray, liver function tests to see if there are any infiltrates, if the liver function, to see, examine for any rash, and liver function tests. Weight gain.
Any infectious etiology that might present like this? Okay, so the liver function test showed transaminitis. The beta-D-glucan was strongly positive with more than 500. Multiple sets of blood cultures were negative, and a USG abdomen showed us diffusely scattered hypoechoic lesions in both lobes of the liver. So this was disseminated or hepatosplenic candidiasis. What do we know about this entity? Presents in patients with hematological malignancies who have recently recovered from an episode of neutropenia. And it really is an immune reconstitution syndrome. Even histopathologically, you'll find granulomas and not suppuration. And the development of symptoms and radiological findings characteristically follows neutrophil recovery or coincides with neutrophil recovery. And it's important to remember that the blood cultures at the time of presentation are typically negative, and even antecedent candidemia may not be observed. So this was a breakthrough invasive fungal infection. This patient was on fluconazole. So important to remember that this patient is azole experienced. Possibility of a fluconazole resistant candida species had to be kept in mind. Dose dependent susceptible glabrata, inherently resistant cruzi, and now auris, as well as resistant strains of tropicalis and albicans all need to be kept in mind when we are dealing with a fluconazole experienced patient. So this patient received an echinocandin for the next 3 to 4 weeks. But as we know, the management of a disseminated candidiasis goes on for months until complete radiological resolution. And it's impossible to continue with an echinocandin for months, both because it's systemically given and because of the cost restraints. We eventually stepped down to voriconazole and posaconazole, and we gave it for several months until complete radiological and clinical resolution. And interestingly here, we used the beta-D-glucan serially. We did it every 15 days initially, then we did it every month until it was negative at a little over 3 months, which sort of gave us a little more confidence that the infection was completely under control. Now, this is not something that's described. It's something that we probably extrapolated, and I'll tell you a little bit more about it. So the beta-D-glucan is a pan-fungal biomarker, as we're aware, and it's a cell wall component of all fungi, including pneumocystis, except for the mucorales, cryptococci, and blastomyces, as I pointed out earlier. There are a lot of false positives. What are the most important ones that we face in our practice? IV albumin. IV albumin is notorious. If it has been given in the past 72 hours, 96 hours, it's going to throw your beta-D-glucan completely off. So that's something you need to remember. IVIG is used less often. And the other important thing is recent surgery. Of course, they say hemodialysis and stuff, but when we've spoken to our nephrologists and done a little more work into this, the current hemodialysis filters that we use do not contain the cellulose that they're talking about. And so we don't see false positives in patients on hemodialysis. What we need to remember is that this test has an excellent negative predictive value. But it's a very, very difficult test to perform. Dr. Anjali Shetty, the clinical microbiologist at Hinduja, who is actually in charge of the beta-D-glucan test, often says that she wants to stop doing it because it really involves, it's really a very tedious test to perform. It involves a lot of, they run the test. They run, for every patient, they run about 2 or 3 samples, and then they look at the average. And sometimes they give an indeterminate value because they find that the 2 values are just so contrasting. So it's a very difficult test to do. And as I said, what we do augur from this test is that it has an excellent negative predictive value. If it's negative, we can sort of say with a very good confidence that this is not an invasive fungal infection that we're dealing with. But having said that, serial values of beta-D-glucan must be encouraged, whether positive or negative. An important question is, how soon do we expect a reduction after treatment? How soon does this test become negative, like a CRP or a procalcitonin? Neither the beta-D-glucan height at diagnosis nor early changes in levels are found to be predictive of clinical outcome or mortality. And while it does eventually decline in patients with IFIs, it lacks any prognostic value within a clinically meaningful time period, which tells us that in patients who have a candidemia or in patients with PCP who you'd be treating for 2 or 3 weeks, it's really of little use to be doing serial beta-D-glucans to see improvement. But in patients like this, who you would be treating for months, in bone and joint candida, who we treat for 6 months, a year, in those patients, we have actually extrapolated or manipulated the slow degradation of beta-D-glucan to our advantage. And we found that it does eventually, sort of months later, become negative, and then you have greater confidence to stop treatment. But we're still building our experience with that. So let's move on to the next case. A 38-year-old lady with AML monocytic differentiation, pH positive, again underwent an allogenic HSCT in 2017 at another institute. A few months later, about 6 months later, had a skin rash, transaminitis. The skin biopsy confirmed chronic GVHD, and she was treated with methylpred, to which there was a marked improvement, and her cyclosporin was restarted. 2 months later, she had fever, productive cough for about 3 to 4 weeks, and you can see the CT scans here, thick-walled cavitary lesions bilaterally. So this is 8 months post-allogenic HSCT. And although we're familiar with this timeline, again, we must remember that these are not watertight compartments. And they're affected by multiple variables, host factors, augmented immunosuppression, GVHD, the antimicrobial prophylaxis that the patient has received. So this patient underwent a BAL, and there were these beaded filamentous gram-positive, partially acid-fast rods. Any takers for what this is?
Nocardia.
Absolutely, bang on. Thank you. So that was Nocardia species, and we know that probably the most important risk factor for this infection is high-dose steroids. High levels of calcineurin inhibitors, history of CMV disease, post-solid and hematopoietic stem cell transplant, advanced AIDS, uncontrolled diabetes, chronic lung disease and alcoholism are now emerging risk factors as well for nocardiosis. So this patient was started on IV imipenem, an oral TMP-SMX, 1 tablet twice a day, double strength. Do you agree with the management? What is true of Nocardia species? Can you have clinically silent CNS involvement in up to 30% of pulmonary or disseminated infections? And so CNS imaging is routinely advised, especially in the immunosuppressed population. Identification of species may not be necessary to fashion treatment. Induction therapy must include injectable antibiotics, predominantly imipenem or ceftriaxone, and the duration of treatment is 6 to 12 months. Does anyone want to discuss these, or do you have any other sort of opinions or takes on this?
Do fluoroquinolones have any role?
We'll come to that. We'll come to that. I've actually decided to throw in a case of nocardiosis just to sort of discuss our epidemiology. So let's look at each of these points. And perhaps the most pertinent from all these is that in these patients, clinically silent CNS involvement does occur in 30 to 40% of cases. And especially in the immunosuppressed patients, even in a patient who has no CNS symptoms, CNS imaging is routinely advised, if possible, an MRI. And why is that? Because not only will the choice of agents that you use differ, you'll use agents that have better CNS penetration, the number of drugs that you use will differ for CNS nocardiosis or disseminated mucordiosis, and certainly the duration of treatment will vary based on the site of involvement. Let's move on to the next 3 points. So this is our data from Hinduja that we've collected over the past 5 years, and we continue to collect. And this was 130 isolates of nocardia that we presented at ECMID last year. And I don't know if you can see this clearly, but most of our isolates were Nocardia cereaceae georgica, that is the species type. About 40 of our isolates we were able to speciate because we have recently acquired Malditoff facility at Hinduja. Earlier to this, we could only sort of get the drug susceptibility, but we couldn't understand the exact species. So most of our isolates are cereaceae georgica. Then we have others, and we have the other isolate, which is Farcinica. What do we understand about our drug susceptibilities? Across the board, across all 130 specimens, regardless of the speciation, there were 3 drugs that were uniformly susceptible. And these were amikacin, trimethoprim sulfamethoxazole, and linezolid. So I strongly urge you to remember that in empiric treatment for these patients, one should consider a combination or at least some of these drugs, these 3 drugs, because these are 100% sensitive for our isolates. Let's look at the 2 commonest species, cereaceae georgica and Farcinica, and look how widely the susceptibilities differed within the species. So it's important to know what the species type is. And I'll tell you that, look at ceftriaxone for cereaceae georgica, 100% sensitive. You'd get away without amikacin in the post-transplant patient with IV ceftriaxone if you have a cereaceae georgica, right? And why am I making this point? Because you will be able to speciate within a couple of days of the nocardia growing. But your drug susceptibility test can sometimes take up to 2 weeks or even longer to come in. So if you just know what your species type is, you would be able to distinguish and start appropriate empirical treatment. Let's look at imipenem. And look at imipenem across the species. Imipenem is actually the drug of choice in most Western studies. Our imipenem susceptibilities are under 40% for all isolates. And you can see the same for our Farcinica, but higher for cereaceae georgica. And similarly with other drugs. So what we're trying to point out here is that there is a marked variation in the susceptibility of our isolates for imipenem, amoxiclav, ceftriaxone, and ciprofloxacin when compared to the Western world. I think Dr. Nishad just asked me about ciprofloxacin. Again, with cereaceae georgica, you have 100% susceptibility for the fluoroquinolone, whereas for the other species, Farcinica, it's just about 50%. So very variable and depending on species. And so it's important to understand our endemicity and choose our empiric treatment, which may be quite different from what the Western data is. So as I just pointed out, variable resistance among different species, time to culture positivity and drug susceptibility is about 2 to 4 weeks. So empiric coverage is strongly encouraged with 2 and even 3 agents in patients with severe infection, disseminated disease, ongoing immunosuppression. The dose of TMP-SMX is higher than in other conditions, 15 mg per kg of the TMP component. Duration of treatment, it should be initial induction with IV antibiotics for 4 to 6 weeks, 2 drugs for up to 6 to 12 months until complete clinical and radiological resolution. And in patients who have ongoing immunosuppression, like the solid organ transplant patients, we have actually continued TMP-SMX lifelong, and this is a recommendation. If not TMP-SMX, any other oral agent that is susceptible, we try to continue it for as long as possible. So coming back to this case, we treated this patient with, or this patient was actually treated elsewhere with imipenem, which was then changed to ceftriaxone. TMP-SMX was appropriately dosed, finally, at 15 mg per kg, and linezolid was continued. And about 6 weeks later, she had a recurrence of these skin lesions. So what could have led to the recurrence of GVHD in this patient? She was on cyclosporin.
drug interaction because of septran?
Absolutely, absolutely. Point on, Dr. Nishad. So use of IV or high-dose oral TMP-SMX may reduce the serum concentrations of cyclosporin to near undetectable levels. And the cyclosporin levels really need to be closely monitored. And this is when she finally sort of was referred to us from another hospital. When 3 months later, she developed low-grade fever, dry cough. She was on TMP-SMX and linezolid. Her cyclosporin levels were adjusted. The GVHD was under control. And you can see her CT scan in April and the new CTs in November when she developed this fever and dry cough. You can see the earlier thick-walled cavity has evolved and is just a sort of thin-walled bulla now. But she has definitely new consolidates over here. And you can see the beginning of a nodular cavity over here. And the radiologist actually said that this represents post-infectious changes consistent with the same etiology of atypical bacterial infection or nocardia. Would you agree over here? Seems unlikely, no? When some of the lesions are healing and evolving and you develop new lesions in another part of the lung. So these patients really don't follow the rule of parsimony. They can have as many immunocompromised conditions, as many opportunistic infections at the same time or at serial intervals. And that's something that we have to accept and we've seen over and over. Her serum galactomannan was negative, it was 0.3. Bronchoscopy was advised, and you can see that the bile galactomannan was strongly positive. Bile smear and culture showed no evidence of nocardia. Again, when you're starting treatment for these patients, very strong caution with drug interactions between voriconazole, oposaconazole, and cyclosporin like you saw for TMP-SMX. And again, cyclosporin and LAMB will have additive nephrotoxicity. When we discuss the galactomannan assay, it's important to remember galactomannan in the neutropenic patient. The serum galactomannan sensitivities are practically the same in the neutropenic host, where they have a much heavier fungal burden. The neutrophils are not there to scavenge the hyphae, and so their galactomannan levels are very high. But in the non-neutropenic population, the serum galactomannan sensitivity is as low as under 40%, but bile galactomannan sensitivity remains good. And in this patient, she had a value of over 3, which is really 100% specific, rules in IPA regardless of the pretest probability. So Dr. Agarwal, can I do one sort of short last case where we haven't actually concluded this case, and the reason I included it was because I needed your suggestions as a hematologist and the suggestions of the sort of faculty here, because this is a first for me as well. Can I quickly go through it?
Yes.
Sorry, Dr. Agarwal, sir.
Please go ahead.
Can I? Okay, thank you. So quickly, this is a 60-year-old businessman from Indore who has myasthenia gravis, and he underwent a thymectomy 20 years ago. He was on steroids and azathioprine, maintenance dose of steroids and azathioprine for 20 years. In 2020, he developed a chronic debilitating constipation with perianal pain and spasm. He had fecal incontinence and discharge. He actually needed to wear adult diapers in time. And he was found to have an anal fissure with an infected perianal skin tag. He was repeatedly operated for this between Jan and March 21 with excision of the anal fissure and tags. He received multiple courses of antibiotics, and the intra-op cultures and histopath were really sterile, inconclusive. This is his MRI. That is the internal sphincter that you see over there, patulous and structurally deformed. A lot of soft tissue there. So this was a low-lying intersphincteric fistula. You can see the opening over here with perianal abscess. He underwent a sigmoidoscopy, which showed this large ulcerative proliferative fistulizing growth suggestive of a neoplasm. In Indore, they diagnosed it as a poorly differentiated malignancy, query carcinoma. And with this report, he came to us at Hinduja, to the onco team. And Dr. Almel asked for a review from the Center of Oncopath. Dr. Anita Borges' team came back saying this is an atypical EBV positive lymphoproliferative a lesion most consistent with the diagnosis of EBV positive mucocutaneous ulcer. Now we understand that this distinct entity was described in 2010, and it has since been included in the revised classification of lymphoid neoplasms by the WHO in 2016. These lesions are confined to the oropharynx, skin, and gastrointestinal tract, and they are characterized by proliferation of these EBV positive atypical B cells, and predominantly seen in patients who have either age-related immunosenescence or iatrogenic immunosuppression. Pathophysiologically, very little is really understood, but we know that after primary infection in the immunocompetent host, the cytotoxic T cells keep the virus in the dormant state. And in these patients, in these immunosuppressed patients, where there is suppression at a systemic level, there are immune modulating factors at particular sites that can lead to localized EBV-driven lymphoproliferation. However, most of these mucocutaneous ulcers have a benign course and respond well to reduction of the immunosuppressive therapies. And in some cases where they've been debilitating or haven't responded adequately, anti-CD20, anti-CD30, and chemotherapy have been used. So in our patient, the steroids, so this patient was referred to us by the oncology team once this report came in, and we spoke to his physician in Indore. We had them stop the steroids and azathioprine, which have been completely stopped for the past 6 months. He reports a 60% improvement in pain, but discharge and incontinence is persistent. The MRI remains unchanged. And if you see the report in detail, it's CD20 negative. It's immunonegative for CD20, but positive for expresses CD30. As per this single case report here, in a patient like this with a similar rectal mucocutaneous ulcer, rituximab actually failed, and they have considered brentuximab for this patient, but they've been using it for the patient, and as per the report, they still don't have sort of a long enough follow-up to understand whether the condition completely resolved or didn't. So I just wanted to know from this sort of August meeting here and the hematologist present here, has anyone had more experience with this, and would you suggest using brentuximab for this patient or anything else?
Anybody?
Ma'am, as you rightly pointed out, these ulcers are usually benign, and reduction of immunosuppression is the first line. But if there are persistent symptoms, you could consider CD20 or anti-CD30 molecules. So the biggest majority of the data is with CD20.
That's right.
And
that's right.
CD30 has also been used, although there are very anecdotal results. I think there is a review of the old histopathology slide to really see whether it is really a malignancy or it is just as EBV positive ulcer is also important here. We have seen patients turning out to be Hodgkin's lymphoma, which are EBV positive. We had a similar case where patient turned out to be EBV positive Hodgkin's lymphoma, who was treated with ABVD and responded dramatically to chemotherapy.
Okay, so you suggest that I ask Dr. Borges for the histopathology and review it elsewhere as well?
Maybe it can be reviewed once again to see if there is any evidence of malignancy and whether PET-CT was done in this case.
A PET-CT wasn't done, but this patient has undergone multiple sort of MRIs of the entire abdomen, and there wasn't anything else apart from this isolated thing. Again, no constitutional symptoms, no weight loss, none of that. But okay, that's a thought. We could do a PET-CT. Dr. Agarwal, sir, any experience with this condition or?
Not exactly this condition, but we have about 5 to 7% of diffuse large B-cell lymphoma, which are CD30 positive. And the experience with brentuximab has been dismal. The only two clear-cut conditions where brentuximab has worked is one which Dr. Nishad mentioned, Hodgkin lymphoma. The second is a T-cell lymphoma, which are CD30 positive. So beyond that, it's all anecdotal.
Right. So I'm happy to take any questions if there are. regarding any of these cases or anything else.
Then you can stop sharing your screen.
Sure.
Ma'am, what is the maximum dose of amphotericin B which can be used?
Up to 10 milligram per kilogram in patients with CNS involvement is the current recommendation. 10 milligram per kilogram per day.
Faculty over here, if you don't mind, you can open your videos, ask questions for both the presentations and the audience. If you want to put some question in the chat box or in the question box, please. Yes. Any one of you?
Dr. Sanjeev
Sir,
here.
Yes.
Go ahead.
For patients who have not responded with rituximab-based anti-CD20 therapy for post-transplant PTLD, usually 1 or 2 lines of failure. Adaptive immune T cell therapy is an option. Allogenic EBV specific T cells are available for treatment of such patients, and usually they respond very well with this. So recently we have a patient of a heart transplant who have a PTLD post-transplant, and he has 2 lines of therapy failure for PTLD, for which we have used allogenic EBV specific T cells, and patient responded after first 2 doses, and he is in remission. All the nodes have become PET negative, so it is an option.
It is a very, very effective option, but I'm not sure whether this is available in India. I have a patient who got
not available in India.
So I have a patient who's in fact the architect of Bombay Hospital, who got this done in New York when he landed up with this after the transplant of his MDS, and he is cured. So they in fact are the innovator of this technology, and they offer it to anybody. So if somebody can afford, one can go there. Dr. Tejaswini, your question.
Sir, regarding TTP, the differential you mentioned as the ANA positive or adult onset Ivan syndrome, and French score, both the scores actually mention a low creatinine level. So if it is a secondary TTP, will that creatinine level of 2.22 or 2.25, will that be still applicable? Have one more question. Should I ask that now?
One at a time. So plasmic score is superior to the French score. That's number one. Second, these scores are valid only till you get the results of ADAMTS13. So they are for emergency use to save the life. So if clinically you are convinced that there is a possibility of TTP, you have sent the levels of ADAMTS13, you are awaiting the results. If your plasmic score is in the range of intermediate or high, then you must start the plasma exchange. If it is low, then you must not start the exchange. Here, when I showed you that case of SLE with the TTP, I must tell you that this is a rarity. So if you have ANA positivity SLE, then you should be a little cautious about diagnosing TTP. And creatinine very high is unusual in patients of TTP. Platelet count not very low is unusual in cases of TTP. So lower the platelet count, less the creatinine rise, it will favor TTP.
So once we get anti-ADAMTS 13 positive, so whatever the score is, it is not immaterial of the score. You can consider it.
So the score was low. You had a cystocytic hemolytic anemia with thrombocytopenia, the mandatory requirement. Then ADAMTS level less than 10%, then you need not probably wait for even antibody. You will at least start the plasma exchange. Antibody will be negative in 25% of acquired TTP. So you don't change your diagnosis just because the antibody is absent. In that case, you wait for the sequencing to know whether it is genetic or not.
The next question is, suppose that the patient is having antibody positive and we are getting plasma exchange for the patient. So there are several methods of plasma exchange, one which we do in the apheresis for the collection of the stem cell. the nephrology has a different method, the ultracentrifugation and the ultrafiltration method. So given that the antibody is a large molecule, is there a different response to the two methods which we were seeing on a day-to-day basis?
I'm not aware of that, because essentially you are not doing it to remove the antibody. You are doing it for removing the von Willebrand factor multimers. And any technology is effective there. Plus, you're also doing it for supplying the ADAMTS. You're not exactly doing it for antibody, for which you're giving steroids, for which you're giving. So
Okay.
I don't think that should affect your type of plasma exchange.
Okay, so thanks.
Right. Yes, Dr. Siddharth.
Thank you for your excellent lecture, sir. So my question is, clinically it looks like TTP. We have started plasmapheresis, but ADAMTS report has come around 20% or something like that. So my question is that is this ADAMTS 13 report is standardized, and whether you can rely on all the reports from all the actually many times in Eastern India actually we're not getting good result from the lab actually. That is the, so what to do in this case? Clinically we are strongly suspecting there are cystocytes and plasmic score is high, but the ADAMTS report is not matching.
Yeah, so that is an issue in large part of the country, and it was there in Mumbai also, same situation till about 10-15 years ago. You keep the patient empirically. We have already discussed the clinical way to diagnose it, and you know all that. But then you continue your treatment, assess the response to the treatment, and accordingly decide.
So in this respect, I want to know, suppose if I want to send a sample to Mumbai or some better lab, so is it possible, or it will degrade if we send it by courier for a better lab for getting better report?
No, there is no problem, except that you must not have given plasma or started plasma exchange. The sample should be collected before that. That's the only requirement, otherwise there are no issues.
Thank you, sir.
Yes, Dr. Sanjeev.
Regarding ADAMTS 13 labels or its antibody or complement labels, recently Dr. Dinesh from SCPGI Lucknow, he has undergone training for this in Milan, Italy, with the ISTH fellowship, and he has got trained for all the workup for this, and very soon we will able to start the all this investigation in our hematology department itself, and we will offer these services.
Thank you, Sanjeev. Not only offer the service, you should have the workshop to train up the other centers.
Sure, sir. We will do that.
Prashant.
Sir, Nishad, sir, in your practice, do you when do you use rituximab? After the ADAMTS 13 levels are available, or you use it upfront?
We are quite aggressive. We have had bad cases. Many times patient is transferred pretty late. So we go rituximab day one itself. We will withdraw it.
And when do you use? And sir, role of prophylactic rituximab, in which cases do you use prophylactic rituximab for relapse?
So relapse is subclinical only if you have got facility for ADAMTS 13. If the level is rapidly dropping, say you have treated the first episode, the levels are 50-60%. Next month the level is 20%. Next month the level is 15%. You know what's happening. So that's the exact case for the prophylactic rituximab, not to allow a clinical relapse to take place, because any one of these relapses could be fatal or morbid. So you have an access to a reliable ADAMTS 13, then you can use it prophylactically. By prophylactic, you mean that the platelet count is still normal, kidney is still normal, there is no cystocytic hemolytic anemia. You're going only with ADAMTS 13 drop.
Okay, sir.
Okay. Yeah, Prashant.
Good afternoon, sir. This is regarding paraneoplastic TTP, sir. A lot of the times the solid tumors are also present with the TTP. In those cases, does the plasma exchange really help, or only the rituximab helps there?
Not really. If you saw the plasma score, one of the pointer was that if there is a malignancy, then it's a negative predictor. So in those cases, you know, even in the ASH, there was a full presentation of where else can you do plasma exchange. And if you carefully read that article, it was a criticism rather than suggesting that you should do more liberal plasma exchange. The outcome was that if you do not have clear-cut diagnosis of TTP, you may start with plasma exchange, but then put an end to it the moment you diagnose something else. Malignancy falls over there. I am very conservative about plasma exchange. Not expensive, technically demanding, complications. So you should be quite sure that yes, you are probably at least have TTP. Now, patients have sometimes major vessel involvement. They have creatinine of 7, 8. They have acute renal failure. The platelet counts are 80,000. You very clinically, you know this is not TTP. So in those cases, you don't do all this. Same applies to cancer. Dr. Shruti? Shruti, you're muted.
This is a typical HUS. Recently, I had a patient of anti-factor H, a typical HUS, where rituximab is in the last dose of rituximab. Still, his bilirubin is high, his platelets have not stabilized, his hemoglobin is down. After I give rituximab, it rises for 2-3 days. Then again, it will fall. So how many more doses can I give? I've started off MMF also, mycophenolate mofetil. Given kidney functions were not very good, I didn't want to start cyclosporine, and monitoring of cyclosporine is also not very easily available. So I started MMF. So how long, can I give few more doses, or I stop with, and we don't have availability of capilacizumab and all those things. So what to do next?
Atypical HUS essentially is anti-complement therapy. And the problem is the eculizumab is not available and it's too expensive. So everything that you are doing or I am doing is unfortunately not the best way to handle these cases. So you have to hit the complement, and that's not available. So it's a diagnosis which you make a diagnosis and you are sort of paralyzed from the angle of effective treatment. So it's a bad diagnosis in our setup at the moment.
Yes, renal functions have improved, but other parameters are not getting better.
It's a problem. Short term, you may get some gain, but it's a problem area. Nishad?
Sir, probably this question should be to a nephrologist, but still, what are the indications of renal transplant in these cases, like atypical TMAs and especially atypical HUS?
So atypical HUS, you are trying to treat the end result. So as I just told Shruti, if you cannot handle the case, then renal transplant, the next kidney will also get damaged. It's just like your myeloma patient where myeloma is refractory. Then doing a kidney transplant is not going to be a solution. So basic disease should be treatable.
Okay, sir.
Also, one more question I had. In PNC, where we have a lot of differentials for TTP, like it's HELP, like it's DIC, it's all, it's not very clear, not very different, and you can find some cystocytes, and you may not have facilities to send ADMTS13 everywhere. So then, if you have strong suspicion that it's not HELP, it is not DIC, you give trial of plasmapheresis or plasma exchange if you don't have ADMTS13 facilities available. And also sending samples for ADMTS13, you require dry eyes and everything. Without dry eyes, you cannot send samples still, and the cost is also too prohibitive.
Last question first. Cost factor can be taken away if you're sending the sample to NIH.
Yes.
It's very cost effective. Then transporting dry ice, your pathologist colleague can help you. That should also be solvable issue. DIC is extremely common. TTP is extremely rare. Cystocytic hemolytic anemia is extremely common. TTP as the cause of cystocytic hemolytic anemia is extremely rare. So I won't jump to plasma exchange if I have a reasonable diagnosis of DIC or any cause of microangiopathic hemolytic anemia. It will be easier for me to do all this if your PT, PTT, fibrinogen, all these are normal. And the platelet count is extremely low despite that. And the kidney is not badly damaged. So if you've got organ ischemia in the areas which we talked about, the brain, the intestine, the heart, and others, there's a very severe thrombocytopenia, there's a frank microangiopathic hemolytic anemia, and there is no DIC, no PT, no PTT, no fibrinogen, no alterations. But you are, Shruti, absolutely right. Easy to talk like this. Bedside, it is quite difficult. If you are not very clear that you are ruled out TTP, you start with plasma exchange. And if the picture unfolds itself, you find somewhere some sepsis or malignancy or some other diseases, some inflammatory diseases, then you know that, okay, this is not TTP, this is all DIC. But yes, DIC is extremely common and TTP is extremely rare.
Recently, I had a patient PNC who started as of DIC, PTA, PTT deranged, platelets were borderline, everything with and in IUD was there, intrauterine demise was there. It settled, and then platelets started dropping. Bilirubin was persistent, and then what was DIC now is like I am initially we treated as DIC only. We did all the possible things, but now like it is like TTP only.
Postpartum.
Postpartum.
And how is the PTT fibrinogen?
PTTVK initially was deranged when there was IUD, but after like once we removed the intrauterine products of conceptus and everything, we cleared everything, but platelets started dropping. Like initially it was 1 lakh, now it is 16,000. Bilirubin, which was like 15 at that time, all indirect. Now it is 8, 9, but indirect. But this is not settling. Other factors have settled. Everything is normal. Creat has improved. PTTK normalized, but platelet not improving, and bilirubin and schistocytes still there. So now I'm treating like TTP.
So now you have microangiopathic hemolytic anemia and thrombocytopenia with no DIC at all.
No DIC at all. Initially, it was started as DIC, but now there is no DIC at all.
There is no organ ischemia of any organ.
No organ ischemia. No organ ischemia. Sir.
The platelets are very low.
Platelets are 16,000, bilirubin is 5, hemoglobin is between 6 to 7, and LDH is strong, retic is 15%, and patient, like I plan to send ADM-TS 13, but there were some issues in sending ADM-TS 13, so we started on plasma exchange.
I accept it. And what has been the response?
So response, actually bilirubin is falling down, platelets are still 30,000, bilirubin is falling down. So we'll continue few more cycles. Pardon, sir?
How many exchanges are over?
Sir, we have done just 3 exchanges till now.
Very early, okay.
Very early.
So anyway, you have some response, so please continue.
Yes.
Normalize, LDH comes down, hemolysis settles, you have proven your point.
Yes.
And must be on steroids also, right?
Steroids have started. Now I am planning to add rituximab also, because long-term exchange is not possible because the cost of exchange is little higher than giving rituximab.
I agree with you. I agree with your management. Absolutely perfect. Yes. Any questions for Dr. Sonawala? Aisha? We have some questions lying down in the question box. I'll just read it out. The questions for Aisha. How do you decide antifungal prophylaxis in non-neutropenic immunocompromised patient who is on steroid? Do you check CD4 cell count or do you check IgG levels?
In non-neutropenic immunocompromised patients on steroids.
That's right.
Right. So again, what we are seeing in this, no, we don't check CD4 T cell counts. We don't check the IgG levels really. If they have been on, so we have sort of wide spectrum of patients who would be on high dose steroids, and we even wonder whether they actually warrant antifungal unless they're on some other immunosuppression or whatever. Because even a patient with TB meningitis will be on a sort of high dose steroid for a considerable amount of time. But question really over here is something like a fluconazole or a voriconazole adequate, or fluconazole adequate, or do you need a mold cover? And honestly, I mean, we've taking from our HIV experience, all right, unless the patient is neutropenic or has sort of some other immune suppression or another pathology which would lead to immune suppression and reduction in CD4 T cell counts, we wouldn't really advocate a mold active cover.
Thank you. One more question for you. What are the indications of initiating isovuconazole? Can it substitute liposomal amphotericin? I asked you in Bombay.
I'm assuming this, yes, I'm assuming this question is for the mucormycosis population. Isavuconazole in the latest sort of global mucor guidelines has been given as a very close alternative for liposomal amphotericin B. And as I showed you, there are some species of mucor that we now understand are less susceptible to amphotericin B. There are some sites of mucormycosis like the CNS, like kidney, where isavuconazole, where amphotericin B penetration is suboptimal. And in those cases, one could think of a drug like isavuconazole. Of course, not for the kidney, but for the CNS. So one very major advantage of isavuconazole is CNS penetration, and the other one being that it has very few drug interactions and lesser side effects. So would I start it upfront in a case of mucormycosis, especially if there is CNS involvement? Yes, I have done that. We initially started when liposomal amphotericin B was not easily available, but if cost is not a constraint and knowing that it's cheaper than using liposomal amphotericin B at a 7 or 10 mg per kg per dose, yes, I would use it upfront in this situation, especially.
Aisha, can I ask you one question about combination?
About?
Combination in, this mucormycosis, despite all this, you lose a lot of patients. So now is there any data on combining these two?
Right. So the data on combining it in terms of having robust clinical studies or evidence-based data for combination is scarce. And that is because of the nature of the illness. There is more data for combination in things like invasive aspergillosis and other invasive fungal infections, but not really for mucor. What I mean is there isn't sort of randomized control trials because they're very difficult to do in this population. But I think that it's a unanimous sort of unwritten thought that in the patients who are at the greatest risk for complications, and that being the neutropenics, the severely immunosuppressed, patients with disseminated disease, patients in whom source control is not possible or inadequate or cannot be completely done, those are the patients in whom combination has been used and is probably encouraged by the entire sort of community of mycologists.
Right. Dr. Aisha has to go. Any more questions for her? Yes, Satish, go ahead. You are.
Yeah, sorry. Thank you, Dr. Aisha. Really enjoyed your presentation. Just had one question in the presentation. You did one of the slides, if you remember, you had showed 2 urine culture reports, one of E. coli and one of Proteus. If that patient was symptomatic for UTI, say that MDR E. coli was a pathogen, and you see that in the sensitivity, the colistin was intermediate sensitivity, nitrofrontin intermediate sensitivity. How do you treat that patient if the patient is really symptomatic and has an UTI?
Right. As per the latest CLSI criteria, you cannot give colistin as sensitive. If your laboratory is giving it to you as sensitive, they are following outdated guidelines. So colistin now, even if the MICs are low, has to be given as intermediate. And what that means is that it is dose-dependent susceptibility. Understanding the kinetics of the polymyxins and the fact that they are poor agents for CR infections, it's indicated to give a higher dose. So that's what they indicate by indeterminate. They don't mean, or by intermediate, they don't mean that it's it can't be used. It means that you have to use it at a higher doses. So you would go ahead and use.
Yeah, no, I agree with you. We are seeing this intermediate sensitivity reports. When do you prefer Zavicefta aztreonam or colistin? Only when it's completely resistant?
No. So honestly, we understand that with colistin and polymyxin, again, achieving concentration at various sites, for example, the lungs, is so poor that Zavicefta aztreonam is definitely a drug of choice for sepsis with pneumonia, like a HCAP or a VAP. All right. Again, penetration into the CNS. So you have any CNS involvement, you would go for Zavicefta aztreonam. Nephrotoxicity being an issue, you would go for Zavicefta astronam. So it's
Okay, so
definitely an easier combination to use at the moment, and better penetration into various sites. What we need to remember is that we are seeing resistance, especially with some of our isolates for Zavicefta astronam, especially in E. coli.
Okay, so do we keep it as a reserve for straight with colistin or for only the sites you mentioned?
No, I've used it upfront in patients who are really sick, who have lung involvement, CNS involvement, neutropenics, immunosuppressed. Clearly, the carbapenem resistance guidelines right now talk about Zavicefta astronam above polymyxins as the drug of choice. Better outcomes, better clinical outcomes.
Right. Thank you. Thank you so much, Dr. Aisha.
Sure.
Sanjeev, you have a question for Aisha?
Yes. Ma'am, what is your call for granulocyte transfusion in patients having severe neutropenia and multi-drug resistance gram-negative sepsis, which is not responding to high-end antibiotics?
Honestly, that is something I keep asking the hematologist, because it's something that we haven't done as ID physicians, but sometimes our hematologists have given granulocyte transfusions, and some agree, some sort of feel strongly that it should be done, some feel that it's a very little benefit because it's only a temporary measure. So honestly, I have no, it's something that has plagued me as well. Sir, do you have any strong opinions on this?
I'm of the other side, that it is useless.
That's what most hematologists tell us, that it's useless. So.
Sanjeev, you are doing it?
Yes, sir. We have published in PLOS only.
Published, but are you doing it?
Yes, we are regularly doing it.
Right.
And do you find that it's actually helpful? It tides over that septic period?
At least it gives a survival benefit. It reduces your mortality.
It's short-term mortality, or even sort of gets you through the long term?
If used in early sepsis, definitely it increases the mortality. It gives the mortality benefit.
So Sanjeev, at the moment you are in UK and you finished 3 months. You saw this being used there in your center?
Not at all.
Okay. And when you used it what? 4 hourly, 6 hourly, 12 hourly? What did you do?
Usually 12 hours.
All right. Shruti, you have a raise hand sign. You have a question? Probably not. I think I should. Yeah. Anybody else? Satish, you have?
So this is for you, sir.
That will do. Anything more for Aisha? Okay, then Dr. Aisha, thank you very much.
Thank you, sir. Thanks for having me. It was a pleasure. Thank you.
Beautiful discussion. It was really an asset to have you today.
Thank you so much. Appreciate it. Thank you.
Bye-bye.
Bye-bye. Bye-bye.
Yeah, now Satish, you go.
Sir, this is regarding the prophylactic or preemptive use of rituximab in relapsed cases where we do see patients without any thrombocytopenia, without any clinical signs or symptoms of TTP, but ADAM13 is going down, especially the women who are planning to get pregnant. So I have a similar patient who before planning pregnancy, the ADAM13 level did come to less than 10%. We gave rituximab 4 doses, and as expected, the levels came up. Now she's in her 24th week. And again, I see that the ADAM13 levels are dropping. It's around 18, 19%, and she's asymptomatic. Have you used rituximab in second and third trimester, sir?
So in this situation, you know, the outcome of TTP is so horrible that you won't mind probably using rituximab during pregnancy. I have used in a simple condition like refractory ITP also. So I'm quite liberal with rituximab. I don't get scared. TTP is a disaster, absolutely. So,
right, sir. Because if you, rituximab usually they say contraindicated in second and third trimester, especially third.
You got to individualize your cases.
Yes, yes. We need to tell the pros and cons to the patient, right, sir?
It's a bigger nuisance than probably the situation. Yes, Sanjeev.
I faced a challenging case. He was a radiographer in our radiotherapy department. He developed severe aplastic anemia, transfusion dependent. Initially, we started him on cyclosporin based immunosuppression, but he did not respond. He has a matched sibling donor. We planned for a matched sibling transplant for him. on day -1 of conditioning, when we started the cyclosporine, IV cyclosporine, immediately next day he developed the features of TMA, and his urine output down. We take the nephrologist opinion, and peripheral smear was also showing features of MAHA, and patient has developed the cyclosporine induced microangiopathic hemolytic anemia. We did all the workup and started the treatment immediately, but patient went into acute renal shutdown, and ultimately he expired on day +28. So my question is, usually in post-transplant setting, when we using cyclosporine as a GVHD prophylaxis, there are high incidence of TMA. What measures can we take to prevent this?
I don't think, Sanju, I'm in a better position to answer this question. I'm not a transplanter, so these cases do not come to me. No experience at all.
Okay, sir.
Right. Any other question? Then probably there are some questions lying in the question box. It'll take about 5 minutes. So one is a comment: daratumumab can also be used for the treatment of refractory TTP. Yes, anecdotally, yes. The question is, what is the upper age limit of presentation of congenital TTP? Well, I haven't seen many patients, but whatever I've seen is in pregnancy. So it has been second or third, say third decade of life. Maximum time interval between Plex and rituximab infusion in TTP, we sort of do it on the day on which you are not doing the Plex, or you do it just before, just after the Plex is over. How do you decide? And fungal, is plasmapheresis of cryo an option for atypical HCUS? My reply will be no. How do we follow up these patients after discharge? How frequently do we repeat ADMTS? When and how to respond to early biochemical relapse, that is ADMTS levels going down? Should we consider rituximab upfront for all the cases? Rituximab upfront for all the cases I'm doing. ADMTS level follow-up, we are just doing it once a month at the most, and then even decrease that frequency. And as we just discussed, if the levels are clearly dropping down, you give the prophylaxis. Follow-up of the patient is once a week after discharge in the beginning, and then we gradually reduce it to once in 2 weeks, once in a month, and then even less often. When to stop therapeutic plasma exchange in TTP? Any strategy to prevent relapse and recurrence? I think whatever we answered, almost the same thing. The moment we diagnose or suspect strongly TTP by plasmic score, we start the plasma exchange. We continue it for minimum of 5 days. The guiding factor is the platelet count, and the LDH both should be normal for about 2 days. And then we follow up this with daily platelet count and LDH to see any immediate relapses, which are quite common, and restart the plasma exchange if required. And once the patient is discharged, I just mentioned about the follow-up, and if possible, do the ADMTS levels intermittently to pick up the subclinical relapses. So those are all the questions over here. I thank everybody for joining, and we have Paresh for the official vote of thanks. Paresh.
Hello.
Yeah, Paresh, we can hear you.
I'm audible.
You are audible.
There's some network issue. It's okay, sir. I'm sure everyone present would have enjoyed this academic quiz today. I would like to thank you both the speakers, Professor Dr. M.B. Agarwal and Dr. Aisha Sunawala, for a fantastic and enlightening presentation. A big thanks to our chief guest for today, Professor Dr. Pradeep Samdani, all the eminent discussants and participants for sparing your valuable time today and making this webinar a success. Finally, I am thankful to Professor Dr. M.B. Agarwal and Mumbai Hematology Group for making Nirvin Life Sciences part of this academic fest. Thank you and good day to all.
Thank you, Paresh, for being with us for 3 hours and supporting our activities. And thanks to Kalpesh and his team from Perfect Square for managing these shows. And have a wonderful rest of the Sunday at home. Bye-bye.
Thank you, sir. It's always a pleasure. Thank you.